the hospital now today.
Yeah, I imagine. Yeah, everyone is in a different office, so yeah. It takes some time. Okay, we're almost there. Hola, Sabrina.
Hola. Javi, que no me puedo conectar, no sé por qué no quería esto.
¿Ya entraste?
Sí, ya, perfecto, ¿me oyen?
Lista. Éramos nosotros los que no teníamos todavía listo.
Ah, ok, no hay problema. Sí, ya que yo ya estoy lista, pues no sé si me va a dar mucho susto, pero bueno.
No pasa nada. Ya te lo digo. ¿Cómo hago para ver el ID de esta reunión para empezar a pasarlo por el número simplemente? ¿Quién me dice?
No hay día.
La gente está teniendo un poquitico de problema, algunas personas para entrar, entonces...
Hasta ahora son todas las reuniones académicas, yo creo.
Sí, señora.
Más fácil por YouTube. Sí, por YouTube entra más fácil. Ahí le mandé el Zoom.
Ok. Ok. Estamos todos listos. Muchas gracias por el cumplimiento absoluto. Gracias. El otro tiene partido de fútbol. Bien. Estamos súper. Tengo aquí un mensaje de algo. Ok.
Ya está en vivo.
El otro tiene partido de fútbol. Muy bien. Ya estamos en YouTube en vivo, está perfecto.
Que por YouTube se ve muy bien, me dijeron.
Súper. Estamos la machera, pero bueno, tenemos todavía unos minutos antes de empezar, 5 minutos, de forma que pueden ir por un café todos los que tengan posibilidad de café.
¿Esto ya está transmitiendo en YouTube?
Sí, ya estamos todos. A Julio ya le mandamos. Estamos ahí listos. Pablo sí se fue por un cafecito.
Yo ya lo tenía aquí.
Nosotros no tenemos.
La plataforma de Zoom no funciona, lo que dice. La de 15 participantes.
Sí, sí, está bien.
Ya se han conectado 9 personas. Se conectó el doctor Félix Borrero por YouTube.
¿Qué machera? Félix está porque me dijo que no iba a poder.
No, yo hablé con él ayer.
No.
Y ya hay 8 personas conectadas en YouTube.
Yo no estoy compartiendo pantalla, ¿cierto?
Voy a mandar saludos al doctor Borrero.
Esta va a ser la entrada.
No.
¿Qué?
¿Para qué lo conectamos todos los tres?
Solo uno con sonido.
Pues para que quede usted también como moderador aparte.
Cuando los otros estén hablando vamos a quitar el sonido, ¿cierto?
Sí, sí, pero pues obviamente durante la charla no hay necesidad de tener la cámara también puesta, pero apenas tengamos discusión les pido el favor de tener la cámara andando.
Claro.
¿Este es usted?
Entonces estoy aquí, ya estoy. Hay algo que está haciendo.
Y cuando hay muchos equipos conectados muy cerquita, como que funciona...
Ponga el suyo en silencio. Ya. Dejamos el sonido solo de este.
Lindo, se destapó el asador. No, pues te pregunto que qué hacemos, que si lo dejamos tapado.
¿Quién?
Lindo.
Bárbara, apaga el sonido. Ahora Lisa está molestando.
Bueno, se conectaron 12 personas y es por YouTube.
Bueno, ahí vamos arrancando. Voy a hacer la presentación inicial en español y empezamos. Explico que vamos en inglés inmediatamente. Lisa está muy...
Se conectaron Camila García, Gómez, Efraín Mendoza, Gracián Tecuanhuey, Código
7:59.
No escucho nada, ¿no? ¿Eco? No.
8. Empezamos. Si estamos listos, vamos a dar comienzo a la segunda sesión de nuestro segundo curso javeriano de ortopedia dedicado a miembro superior. Entonces, quiero darle la bienvenida a todos a esta segunda sesión del curso, hoy dedicada completamente a mano infantil. Les agradezco, les recuerdo, la semana pasada tuvimos nuestra primera sesión dedicada a cirugía de hombro con los expositores que ven en la diapositiva. Afortunadamente fue muy exitosa y les agradezco por venir hoy otra vez. Para hoy tenemos también un panel de expertos que nos va a ayudar a acercarnos al conocimiento de la deficiencia longitudinal radial y de las lesiones obstétricas del plejo braquial. Primero tenemos a la doctora Andrea Bauer. Ella es ortopedista y cirujana de mano del programa de la Universidad de Harvard y también tiene otro fellowship en el mano infantil en el Hospital Schreiner. En este momento es profesora asistente de la Universidad de Harvard en el Children's Hospital de Boston y una persona con una cantidad impresionante de publicaciones en esta área. De Medellín tenemos a la doctora Sabrina Gallego, médica de la Universidad Pontificia Bolivariana, especialista en cirugía plástica de la Universidad de Antioquia, con especialización también, paso por el Instituto de la Mano en París y también cirujana plástica oncóloga, también con una gran dedicación a la cirugía de mano infantil. En este momento trabaja en el Hospital San Vicente de Paúl, profesora de la Universidad Pontificia, de la Universidad de Antioquia, perdón. Y de último, pero no menos importante, el doctor Pablo Zancoli, de Buenos Aires, quien hizo su residencia en el Hospital Naval de Buenos Aires, con fellowships de cirugía de mano en el Instituto Kleiner, y él en el programa Mielina de microcirugía y plejo braquial. Ellos tres nos van a estar hablando acerca de los temas de deficiencia longitudinal radial inicialmente y después parálisis obstétrica de plejo braquial. Tenemos bastante tiempo para disfrutar las conferencias y para tener una discusión lo más rica posible. Entonces, los voy a dejar con la doctora, perdón, vamos a empezar, me perdió todo, ya. Empezamos con la doctora Sabrina Gallego, quien nos va a hablar del espectro clínico de las deficiencias longitudinales radiales. En este caso, quiero contarles que, pues, como tenemos a la doctora Andrea Bauer y queremos tener la discusión lo mejor posible, nuestros conferencistas han estado de acuerdo en presentarnos sus conferencias en inglés. Las preguntas serán recibidas tanto en español como en inglés. Ustedes saben, tienen la posibilidad de ir poniendo las preguntas en el chat, tanto en la plataforma de Zoom como en YouTube, y van a ir siendo, vamos a incluirlas en la discusión en la medida en la que vayan llegando. Entonces le doy la palabra a la doctora Sabrina Gallego para empezar. Sabrina, adelante.
Hola, buenos días. Me saludo en español. Dr. Bauer, hi, how are you? Nice to see you too. Y bueno, vamos a comenzar esta sesión de hoy, de esta mañana, hablando de la deficiencia radial. Como dijimos, vamos a empezar en inglés entonces. The entity have many names, since radial club hand, preaxial hemimelia, and radial longitudinal dysplasia has been known as for decades like that. Adrian Flat, in his book in 1994, he wrote that a comprehensive classification of congenital malformation is possibly never will be complete and easy to understand, and and probably could never get all the malformations we have, because there's a wide range of malformations. So the first classification that was published or popularized was the one for France and O'Reilly, and they classified the radial dysplasia as a paraxial hemimelia of the radial side. The Swanson classification, adopted by the International Societies of Surgery of the Hand, classified in the category 1, failure of malformation parts, longitudinal and radial. They tried to group all the malformations according to patterns and the structures that were most affected. So that's why we call it radial longitudinal dysplasia from there. Even though after 16 years, we haven't been able to get a comprehensive and easy classification, probably because it is too hard to classify those malformations. So in 2010, the OMT classification was published, and the new update now includes a lot of new categories, but the radial longitudinal dysplasia is classified as a malformation of the radio-ulnar or anterior-posterior axis of the limb. I'm not going to talk about embryology a lot, but at least I'm going to remember you that there's 3 zones of that direct all the growth and the development of the limb. The most important is the apical ectodermal ridge. It guides the development from proximal to distal. The other one is the zone of polarizing activity that guides the radial, ulnar, or anterior-posterior differentiation, and the wingless type is the one that guides the differentiation between dorsal and dorsal and volar aspects of the hand. When we call preaxial a deformity preaxial is because in the embryo, the thumb or the toe side were localized cranial in the fetus, so they call it preaxial for that. So that's why we call it like preaxial to all the radial or to all the malformations or conditions that are at the side of the thumb and the toe. We don't know exactly the etiology of radial longitudinal dysplasia, but it's proposed to be an insult during the 4 to 8 weeks of embryo development. It could be from an anoxia, irradiation, hormones, vitamins deficiencies, drugs, viral infections, we don't know. But there is a wide spectrum of malformations of deformities within the radial longitudinal dysplasia. And it depends on how big, in what moment, or in what specific point of the epidermal ridge was the insult, and that is going to be that is going to make the expression, phenotypical expression of the deformity. So we have to count that this is a spectrum, like its name says. And we can have a bilateral is the more frequent. Normally when there is bilateral, it is asymmetric, and we know the more, let's say, common radial, known as radial club hand or radial longitudinal dysplasia in the forearm, but it can include from the humerus to all the radial aspect of the limb, and has involvement of complete or partial segments. 1 to 3% of newborns can have malformation, and 10% of newborns with congenital malformations can have an upper limb deficiency. Radial longitudinal dysplasia is calculated to be 1 in 5,000 to 1 in 100,000 live births. It has a male-female ratio from 3 to 2, sorry, and it can be bilateral until to 60% of cases. When it is unilateral, it's more common on the right side for 2 times. An important thing that we have to count on is that all the radial longitudinal dysplasias are most of them are have associated conditions or syndromes, and this is important because we have to make a big or an extensive workout, especially for the Fanconi anemia. That is a condition that can kill the kids if it is not treated well. Another important thing are the bacterial associations and the whole Oram syndrome that has a lot of cardiac malformations. The classification that we use is the modified, the Bain and Club classification. It was proposed in 1984, and it was modified in 1999 for James and colleagues. The first one by Bain and Club didn't include the normal carpus or normal radius. So they include, the normal hypoplastic or the normal carpus and the normal distal radius. But they modified it, including these 2 types, the N and the 0 types. And it is based on the radiologic views or classification of the bone deficiency. This is that type N with a thumb hypoplasia, and a type 2 with a carpal fusion and absence of the scaphoid and other bones. This is the known radial longitudinal dysplasia, or the more common, not the type 1, but that we actually known as a radial longitudinal dysplasia. The type 1 is when the ulna is 2 millimeters larger than the radius. And the type 2 is when it is a hypoplasia of both distal and proximal ends. This is the same patient, 3 years and 17 years. It is a hypoplasia, and sometimes it is deformity of the ulna. This is the type 3 deformity when we see a proximal normal radius, but an absence of the distal radius with all the malformations associated in the thumb and carpus. And this is the type 4. It is the complete abscess of the radius bone, and is the more frequently presented. Sometimes more than a third of patients are a type 4. Thumb deformities, we use the modified Blount classification to classify thumb hypoplasias or deformities. And it is used also in conjunction with the Bain and Clark modified classification. Remember, when it is a bilateral condition, most of the times it is asymmetric, and we can see how different presentations are in each limb. Look, he has a good ulnar digits, but his radial digits are not so good. He has here a thumb and hypoplastic thumb, but probably these digits move better than this one here. So we have to know that most of the functional prognosis, it depends on the mobility of the fingers. Another abnormal features we see is the general hypoplasia of the upper extremity never is going to be as large as it was going to be if we were normal. Sometimes we have absence of active elbow flexion. Fortunately, this improves with age. But when we have a patient without active elbow flexion, we have to think about correction of the wrist deformity, because normally the wrist deformity acts as an elbow. There is shortening and bowing of the ulna, absence or hypoplasia of any carpal bones. The thumb is always affected. And as I said before, it can be a limited motion of fingers, especially the radial ones and especially the index finger. Muscle alterations can vary from for hypoplasia, fusions, variations in insertions and origins. And it is important from the surgical point of view when we are going to do treatment, because as they are not normal, we cannot use the regular techniques that you use in a normal wrist to improve the deviation of the wrist. We cannot use sometimes these tendons or these rudimentary tendons or fibrous tissue to improve movement, and sometimes to improve to make right the hand, we have to cut on all the tendons, distal tendons, and we have to sacrifice some movement. The nerve compromise is that of the radial most of the times. It is truncated at the level of the elbow or at the forearm. Ulnar nerve and axillary nerve are normal most of the times. It can be affected also the musculocutaneous nerve, and all the affected nerves are replaced for an hypertrophied median nerve. Sometimes there is no sensitive or motor deficiencies that we can see, but this hypertrophied median nerve is always replacing the missing nerves. And the most important thing when we are doing treatment is that they are more radial and more superficial than normal, than in normal patients. Vascular variations also include amputation of the radial artery. Sometimes it can be no artery at all. But normally the interosseous artery can be bigger and can aid in the formation of the palmar arch. The most important thing when we're going to operate on thumbs or in distal to the hand is to see that we can have also variations in the digital collaterals arteries. And if we're going to think about doing polycization, we have to take care of the ulnar collateral of the index, because sometimes it is the radial is absent. Other associations that can be found and are more rare are the polydactylia and radial hypoplasia, described in this case and in a family, and they think they can have syndromic cases in families. And congenital radial and ulnar longitudinal deficiencies in the same patients. So we see here that in one side is ulnar deficiency and the other one is radial deficiency. So it was all that I have to talk about the spectrum. We see that we have a lot of different ways in presentation of this entity, and it makes it difficult to treat. Thank you very much.
Thank you so much, Sabrina, for your talk. Now it's time for Andrea to start talking about treatment. Please share your screen, please.
Yes, thank you. And thank you so much for having me. I'm so sorry that I can't be there in person, but I hope to be there in person someday soon. I'm assuming that everyone can see my slides and hear me unless you tell me otherwise. So I'd like to acknowledge much of the work that I will talk about and much of what has informed my thoughts on treatment comes from the Texas Scottish Rite group and Dr. Mary Beth Azaki. And my colleague, Dr. Carly Villerman, trained with her and has brought a lot of her thinking to Boston and has really changed the way we have begun to treat radius deficiency in the last few years. And Sabrina described the spectrum of radius deficiency very well. And I think for the most part, the most difficult ones to treat are the type 4 radius deficiency, and that's what I'll be focusing mostly on. Also, as Sabrina mentioned, an important part of treatment is treating the whole child. As a pediatric orthopedist, we want to identify associated conditions early on. For the residents in the audience, this is always tested on exams as one of the few times as a hand surgeon you can save somebody's life by diagnosing Fanconi anemia and getting treatment early enough. You can really make a difference. And then beyond the initial diagnosis, in young children, we start with stretching and either serial splinting or casting. Here's a picture of a typical splint on quite a small child. And that can be very helpful in terms of improving the passive range of motion, not only of the wrist, as you think about treatment of the wrist, but also of the elbow and of the fingers, which is very important in terms of overall function of the arm. And then we'll talk about some treatment controversies in terms of surgery for the wrist. And I think that treatment of radius deficiency falls into one of those orthopedic axioms that if there are many treatments available for a certain condition, either all of them work well or none of them work well. And I think, unfortunately, in radius deficiency, it's more that none of them work well, and we, would benefit from a more biologic solution, I think. But this is what we have so far. And so, in terms of surgical options, so it's not just a bony problem, it's a soft tissue problem. And so soft tissue releases, distraction, and tendon transfers are all part of the treatment armamentarium. We'll go through some skeletal rearrangement options, including centralization and radialization, as well as ulnar osteotomy. And then I will not be talking about this here, but just to mention the concept of an MTP joint transfer and the Wilke procedure, which is a really interesting but complicated way to provide some radial support, and then salvage procedure of arthrodesis. So centralization, the principles are still soft tissue rearrangement, and that's a feature throughout these different options. But the idea of a centralization is to take the carpus and center it onto the third metacarpal. This can be done, as in this picture, with an osteotomy more proximally on the ulna if needed. And this is a great idea. Why not just turn the ulna into a radius? Initially, this is one of the early outcomes. You can see the names Bain and Klug from the Bain and Klug classification, looking at 64 patients, and they found that only in that group, in longer term follow-up, they only classified 21 of them as having good outcomes. But Gramco said that if surgery was done early, they could have a remarkable improvement in their aesthetic appearance and fairly good range of motion, but this was only an early follow-up. As we look at longer and longer term follow-up, more problems become evident with centralization. So in this series from St. Louis, looking at 20-year follow-up, the average hand forearm angle had gone back to 25 degrees. Average wrist motion was only 31 degrees. Grip and pinch strength were pretty poor at 20% of normal. And the average ulnar length was 54% of normal. So quite short forearms in long-term follow-up. And what they found when looking at patient-reported outcomes is that improvements in the wrist alignment and the ulnar length did not correlate with function. And so we're addressing this radius deficiency problem with a surgical solution that has complications, and we don't even know how our improvements correlate with improvement in function. Certainly there are some contraindications to centralization. So if the elbow is stiff, let's see if we can make it so if the elbow is stiff out in front of you and your wrist is in a radial deviated position, you can still bring your hand to your mouth with a stiff elbow. If you have a stiff elbow and you do a centralization, you put the wrist farther on the end of the ulna, it actually puts the hand farther away from the patient. And so a stiff elbow then is a contraindication to centralization. Also, one could argue the same thing for ulnar prehension. So patients who use their small finger to interact with the world, again, you would be putting that farther away from them with a centralization. And then we'll go through some of the complications, including recurrence, as we talked about, and physeal arrest in more detail. Just a brief note on radialization. I think of this as mostly a historical procedure, but the concept is that if a centralization has the complication of recurrent radial deviation, why not be a good orthopedist and just try harder? And so the Buck-Gromko radialization is to align the ulna farther over radially with the second metacarpal. And that then perhaps decreases the risk of recurrence, but has a greater risk of stiffness and physeal arrest because you're really overdoing it with that centralization. And so I would say that this is not something that I think that we would do anymore. And then one of the ways people have thought of to perhaps decrease the recurrence or to decrease the stress on the ulnar physis is to do a pre-centralization distraction. And so for these type 4 radius deficiencies, if we're going to try to bring the hand onto the end of that ulna with such a tight soft tissue envelope, maybe this distraction could be helpful. And this image is of a uniplanar device. People also use ring devices, all kinds of different methods of doing this. Interestingly, when the group at WashU looked at this, they compared 13 patients that had a centralization alone with 13 that had pre-centralization distraction. And the surgeons all felt that the distraction facilitated attentionless centralization. So we feel better about our ability to do the operation when we do the distraction first for these really tight radius deficiencies. But both groups had significant improvement in the resting wrist position after their centralization. And there was actually a greater recurrence in the distraction group. And the ulnar length was similar between the groups. So neither, if the centralization is done carefully, even without the distraction, there was no evidence of ulnar physeal injury in either group. And so although many times we continue to use these distraction devices before centralization, there's not really any great evidence for them based on this most recent study. And this is just a example, and obviously these are small groups, but the blue was the centralization alone group, and the red was the distraction group, looking at the radial deviation, where you can see that at final follow-up there was a high, statistically significant higher amount of radial deviation in the distraction group. And so the group in Texas Scottish Rite came up with this idea of a soft tissue release and a bilobe flap for improving motion without doing an underlying centralization. So these children have an unusual setup at their wrist. We can do tendon transfers, but don't try to put anything in a fixed position where it's not. Just try to improve the motion, balance things out as much as you can, and make it look as nice as possible. And one of the studies that my partner, Dr. Villerman, did was looking at how this bilobed flap helps with ulnar length compared to other procedures. And what they found was in notched centralization, so where there's actual bony work done to fit the carpus onto the ulna, they found about 50%, the ulna was about 50% of expected length. In non-notched centralizations, there was still some shortening compared to the expected length, but not as much. And then on this graph, this is normal. The blue one is normal, and the pink is the bilobe flap, and all of these below here are historical papers about centralizations. And so you can see that the ulnar length, when you do a bilobe flap in a soft tissue procedure, much more closely matches the normal state compared with the centralization. And so we, from leaving the skeletal elements alone, we can allow the ulna to grow to its fullest potential. And so they really believe, and I am starting to believe, that this is so far the most ideal procedure we have to address the wrist deformity. We can correct the deformity, and particularly the aesthetics of the deformity, very well with this bilobe flap, while preserving the ulnar growth, preserving motion. And it does give you the ability to do another procedure when the child is older. So if they really want a stiff, straight wrist when they're older, you can do a wrist fusion, an ulnocarpal arthrodesis. If you really think, if you're a technically excellent microvascular surgeon and you really believe in the Wilkie procedure, you could do that, the free MTP transfer, later. And so this allows for more time to consider alternative procedures when the child is older without burning any bridges. And so these are just some pictures of what it looks like. This is a dorsal version. I have since switched to the volar technique because it puts the scar on the volar side of the wrist. And through the flaps, obviously these are fairly big random pattern flaps, and so it's important to not touch them, dissect them very carefully using all of your plastic surgery principles. And beneath the flaps, then the same types of tendon transfers that you would do and releases that you would do in a centralization are still done. You're just staying out of the joint capsule, out of the, away from the physis, and trying to be very gentle. And then by doing the flaps volarly, you have a scar that's only on the volar surface of the wrist. And so this is a study that was done in Texas, looking at children with a minimum of 3-year follow-up after the bilobe flap procedure. And what they found is that they did have ulnar deviation afterwards. This was improved, but not, not improved to the extent early on that a centralization would improve it. But what they did find also is that they maintained motion. And so there was much better motion following this procedure than after a typical centralization. There were no ulnar physeal injuries and a resting hand forearm angle on X-ray of about 50 degrees on average. So, and this is just an example of some post-op scars where you can see, really nice aesthetic appearance. So I think the biggest argument for this is that it's safe. It preserves movement, it preserves growth, it improves the hand position. And as I said before, if secondary procedures are needed, they can still be done in a relatively virgin state here. Any questions before we move on to some cases, either about my for me or for Dr. Gallego? I do see one in the Q&A. At what age do you recommend to start surgical treatment? I think that's a good question. My preference is for a child that, and I think it depends on whether they have radius deficiency and thumb deficiency or not. So for a child who has both, my preference is to try to get the radius procedure, the wrist procedure done first, and then the thumb procedure. And I like to do pollicizations around a year of age. And so I'm typically doing this procedure somewhere between 6 and 9 months of age for the bilobe flap, and then 3 to 6 months later doing the pollicization. But I think this could still work at age 2. I don't think it really, I don't think it has to be that early. Let's see, I have another question. What is more functional, an aligned rigid wrist or a mobile deviated wrist? And I think, again, fantastic question. There was an interesting study that actually won an award from the Mansky Foundation by Kotwal and colleagues. I think it was 2014 out of India, where they looked at a large number of patients who had undergone centralization or not for radius deficiency. And they found that patients post-centralization were more functional than those who had not had a centralization in terms of hand function after surgery. But what it most correlated with was finger motion and grip strength. And so I think it's tough, depending on the position of your in the position of your wrist, which of those things is better. And all of our, many patients who have had both operations are happy with what they've done. I think that once we buy into a strategy and we discuss this with the families see our vision and they're happy with what they went through. But it's very challenging to know which one of those is truly better, I think. Let's see, and a question, after the bilobe flap and soft tissue release, do you use some sort of casting? Yeah, and I can share in one of these cases, or I think 2 of these cases go through, I'll still often pin them. It's still somewhat of a centralization, and so I might pin them and cast them for a month, and then continue with splinting for really as long as the child and the family are willing to. I will continue with a nighttime splint to try to keep them out of radial deviation as long as possible. I think.
Thank you, Andrea.
Yeah.
I don't know if I didn't pay enough attention, but what do you recommend right now for a child with a marked deviation in the risk? Do you go for most patients with just the soft tissue release and the bilateral flap right now?
Yeah.
Is the end of centralization.
That's my preference. I think particularly in the ones that are very tight and very radially deviated, I think that I want to give that ulna the best chance to grow. And I don't think that I know from the generation of hand surgeons before me that what I might think is a great centralization at age 2 is not going to be great at age 20. And so my preference is the bilobe flap. But I think also this is an area where we need a better solution. We really do.
Okay, and I have a question for Sabrina and Andrea also. When I was doing congenital cases, we received some information against surgery before 1 year of age. So we started delaying patients for later than a year. And now you're telling us you are operating from 6 months old. And you work at the Boston Children's, where all the science starts. So what is the position of pediatricians and anesthesiologists over there for this elective surgery before 1 year of age?
Yeah, I would be interested to see what, Sabrina, what you're doing at your hospital also. I think we have not, some of those anesthesia, so the risk after age 6 months, the reason why people are saying to delay after a year is the thought that there may be some type of neurotoxicity from anesthesia on the developing brain. Some of those studies have been done at Children's, and our anesthesiologists don't seem to think that the risk is as high as some other anesthesiologists, such as at CHOP and in Cincinnati. And so they are okay with us doing things if we truly feel that they're indicated. I would say things that don't, other things that are more elective, like a trigger thumb or a thumb duplication, a post-axial polydactyly, we would save until after a year. This, I think the reason I push it sooner is to try to get through the stages in time for the child to develop their pinch with the thumb that they're going to have.
Thank you. Sabrina, what do you think?
We've seen here more small children day to day, because before we saw them too late, 5 or 6 years, or even when they were adults. So now we're seeing it sooner, and around 1 year we do the operations in those kids. Also, and it depends, because if you have a ulnar prehension with the little finger, you see that you cannot be able to do apollicization, so you can wait a little longer. It depends on the other pathologies of the children and the size of the children. And if you're not too experienced, it's more difficult to do it when the children is smaller than 1 year.
Okay, we have another question, which is what could be the explanation for more severe recurrence using external fixation distraction?
I have no idea. I think that was a very surprising finding of that paper. I don't know if it, maybe we're still, even when we think we're doing the distraction slowly, maybe we're still doing it too quickly. Maybe it's that the amount that they got was more. And I think, it was a retrospective study. And so it was not like a randomized controlled trial whether the patient was getting that distraction or not. And so presumably the surgeons were deciding to do the distraction on the worst cases. And so it may just be that. Thank
you. I think we can see the cases and then some more discussion after that. Thank you. Sure. Do you want, Dr. Garcia, do you want people to weigh in on the cases? Yeah, we might. We have some very, very experienced surgeons in the audience, so we can have their input too. I will go including them along the cases. You're okay with it. Thank you. So let's see. So
So this is a child that was, this is a case from Dr. Azaki, presented a little bit later, but the elbow, so this is a child with radius deficiency. The elbow was stiff at birth, but now with stretching and splinting, they have flexion to at least 100 degrees at the elbow. The wrist is still stiff in radial deviation, and they have ulnar prehension. And so these are some x-rays. So for a 4-digit hand, you can see quite a significant hand forearm angle, type 4 radius deficiency. And these are pictures of Dr. Ozaki trying to straighten the wrist out, so you can see the amount, you know, it is quite quite far over there. So I don't know if you, I think we know what my answer is for this case, but it'd be interesting to see what others would do in this stiff radially deviated patient.
Maybe Sabrina, if you start, I'm going to give to open the mic for Jaime Forigua and Dr. Vergara.
Probably I would do distraction, pre-centralization, distraction, and then distraction.
Any other comments?
¿El caso o no? Enrique. Pablo. No les puedo dar. I'm sorry.
Oh. Did I keep going?
Yeah. Okay. I was thinking like I would like to prefer to do the centralization. To me, it's very important to evaluate the stiffness and even the elbow motion. For the surgery, the age of the patient, it's around, as Dr. Garcia told us, around 1 year old. I say we have a lot of troubles with the extraction previously of the real surgery. Unfortunately, we have some complication like metacarpal, carpal metacarpal dislocation with the using the external fixator.
That's a good point. So, like I said, you know what I'm going to say, which is the soft tissue centralization. So I'll take you through the steps of this. So again, when you place the flaps volarly, you can see really, you know, limited scarring on the dorsal side. This is the way that they're drawn out. And this one then is going to be closed down as it gets rotated. Those two lines just come together. Here the flaps are incised, and you can see again really full thickness flaps. We try to keep the fascia on the flap to allow as much venous drainage as possible. You can get venous congestion from these because they are random pattern flaps. But you can see they're, you know, wide release so that they're able to be transposed, and then the wrist will be able to be closed on that radial side, ulnar side, sorry. And then here, the same types of things that we would do in terms of tendon releases and things and transfers can be done right through these flaps. And then again, just like we had talked about, here's, you know, once the position is achieved, still placing a pin, but and holding that position. And even even if you have no intention of making the wrist any straighter, this does help also with the flap congestion. Just limiting the motion will help with the flap healing. So there, and it's similar to how you might place a pin in a formal centralization. And there's the appearance after surgery.
Dr. Bauer, have you had any lymphedema after this bilobe flap?
No, but I have had some vascular congestion. One that had some sloughing of the epidermal layer on one of the flaps. So I think that certainly, they're big, so that certainly can be an issue. Yeah.
Okay.
And then for this case, so this is a patient of mine that presented very early. She had vectoral sequence and a very large ulnar bow. She does have radial prehension, although, and these are just to show how early she presented. This was her at 4 weeks of age. And you can see 4 digits, very significant ulnar bow, where it's difficult to even sort out, like, where is the elbow in this child? And these were her x-rays. And what I find interesting about this patient is the carpus is not that angulated from the end of the ulna. The issue really here is this huge amount of ulnar bowing. And this should have clued me in earlier on that she had a cartilaginous radial onlaga here. But it didn't until the time of surgery. But I think that's something to consider is, these are all different. And this, I think, was an unusual presentation of a type 4. And maybe it's not for you guys, maybe this is every day for you, but for me, seeing this kind of 90-degree bow in the ulna didn't set off the thought that perhaps there was a radial tether there. But I think in the future now that will. And so my plan for her was an ulnar osteotomy, more proximally than combined with the soft tissue centralization and the bilobe flap. And so here, this is the pin that's going to be intramedullary in the ulna. Here is the location of my planned osteotomy. That's done just through the dorsal, tiny incision on the dorsal surface of the ulna. Here you can see I'm not lying about how early I operate on these patients. This is my finger and this is her ulna. And so, certainly still quite small at the time of the operation. And then once the ulnar osteotomy was completed, I passed the ulnar intramedullary wire here, and then a second wire to stabilize the wrist and the flap. And I don't have intra-op photos of her. I have them, I couldn't find them. But it was that same volar bilobe flap along with some tendon transfers. And then here you can see on this picture, this is where we cut through the radial onlaga, and where we made our osteotomy of the radius, there's now some bone that's formed. And you can see, she still has some deviation, but a much straighter ulna. And then this is what her scar looks like. And so, still a short form, still deviated, but a significant aesthetic improvement. And again, I think it's hard to get a handle on, one procedure versus another. We talked about this with her parents as not burning any bridges, and they're thrilled, with this outcome. And perhaps if you told them that this was going to be perfectly straight at the end, they would not be thrilled with the outcome here. And then this was done. So this was done about 9 months of age. And then I don't have pictures of her policization, but we went ahead with the policization around 14 months at that point. At 14 months of age.
Well, that's a great case. I have a question over this case and most of these kids, they start complaining when they grow to 5 or 6 because of the length of the limb. do you start doing ulnar lengthenings during their childhood, or do you ask them to wait until their full growth is over?
Yeah, I try to sell this as a length preserving and a length maximizing procedure. But I have not been happy with the results of ulnar lengthening. I think that patients, it's interesting, Francisco mentioning that, some of the complications that you've had just with the soft tissue distraction. I think people, particularly families, really underestimate how hard it is to go through those procedures, the challenges, the fact that it often needs to be done more than once. And so I really try to avoid it if I can until they're older, at least age 10. I think they can maybe have a better sense of whether they really want to go through it. But okay. I try to talk people out of it.
Okay, I see. Well, we have Enrique Vergara, who is a very, very experienced hand surgeon in Bogota. He's with us. Are you there, Enrique? Not willing to talk? This is great. Okay, I have actually treated several patients during their whole childhood, and in several of them, I performed ulnar lengthenings during their childhood, later childhood, 8 years old, 7 years old, and it works all right, but sometimes you have a recurrence of the deformity, a little bit of a recurrence. So what I started doing later was to include the carpus in the fixation. So sometimes with occasional wires, just to make sure the soft tissues don't pull radially the hand, but not many complications for the lengthening procedure. So they go okay. Sometimes some of I remember one of the girls, she had a later bowing of the ulna after the lengthening. So she started bowing by herself after the lengthening. So we needed later to do an osteotomy and fix it with a plate when she was about 12 years old. But they are very thankful for the lengthening, mostly when it's bilateral. Sometimes you take them to the perineal care, so that's a huge improvement for them. Any more cases now? Any more discussion?
Well, I think you're definitely right about the bilaterals, that if you have two short forearms, that can be very disabling. And so I think those are perhaps the patients that are the most grateful for a little more ulnar length. I do have one additional case if you want to go through that. So this was just a fun case to share with everybody. It has nothing to do with radius deficiency.
Okay, let's see it.
But this is just one of my favorite patients. So 4-month-old, completely healthy girl, first child to wonderful parents. And it says on our little clinic sheet, extra fingers and toes. And here are her hands. So indeed, some extra fingers, and she has some syndactyles. And I think, it's difficult at first to say, well, which is the radial side and which is the ulnar side in this hand. And these are her adorable feet at presentation. And so eight toes on each foot and 6 fingers on each hand, with no family history and otherwise completely healthy. And I think, as orthopedists, I think looking at x-rays always helps us. Here, you can get a sense that she tried to make some thumbs. This is her left hand and this is her right hand. But, there's no first web space, and everything is in the same plane. And then on the feet, you can appreciate really just how wide all of this is. And in terms of gait and shoe wear, in Boston, being able to get some warm shoes on your child early is important. This was really, going to make things difficult. And so I think for a case, an unusual congenital case, it's important to take a step back and say, okay, well, what are we trying to achieve here? So our thoughts were, well, we want to get down to 10 fingers and 10 toes, which I think we can do. As part of that, we want stable opposable thumbs with an adequate first web space and independent digits. In terms of the feet, we really just need them to be narrow enough for shoes. We want to minimize trips to the operating room. And then when it comes to planning, we think, well, it would be nice to be done by the time she starts preschool, in terms of the trips to the operating room and the intensive therapy and things like that, as she's going to be meeting her friends and learning how to use a pencil and, developing her handwriting, developing her fine motor skills. It'd be nice if we were done and she had the fingers that she was going to have. And then I think an interesting question also is how important symmetry is in terms of what you do. And so, if we go back to these x-rays, her hands are a little different. There's 3 syndactylized digits on one side, only 2 on the other. The thumb on the right is perhaps relatively well formed, although there is this little ossicle here. The thumb on the left is triphalangeal, and maybe that, could be an issue down the road. And so although those were a little bit different, and again with the feet also, a little bit different in the configuration of the metatarsals here, how important is it that your procedures are symmetrical? And so this is what we came up with. So we started, so my thought was, I'm fortunate to work at a children's hospital where there are a lot of talented surgeons. And so the first 2 stages were done simultaneously, hand and foot surgery. We wanted to stage the syndactyly releases with the foot surgery so that the foot skin, as the toes came off, could be used on the hands. And so we came up with a bilateral syndactyly release done on one day with the left foot. We also always had to leave a limb free so our anesthesiologist didn't get too mad at us. So we had bilateral syndactyly release with the left foot, and then the second stage 3 months later was a web release on one side and a policization on the other, and then the other foot. And then on the last day, all I had to do was a policization, and that felt easy. And we staged these 3 months apart. But just curious if there's, I think there's lots of things you could have done here. I chose the policization because I felt like on that try, it solved both the 5-digit problem and the web space problem, and the thumb opposition kind of solved all the problems in one operation. But I think you could argue whether that was the correct finger to take off. So I don't know if there's any comments on that. I could go back to
I don't know if Sabrina has. Well, my thoughts are, well, we have in this hand we see on the left side, I don't know, it's the left hand, the one we see on the left. Okay, that one looks a bit easier for me. And if we start counting from ulnar side to the radial side, we have the 4 long digits, which have a nice shape, and we have a simple syndactyly, which should not pose any problem for any surgery. So we have to choose between those two fingers we have on the radial side for the policization. I see that the most radial one is, I see it shorter. I don't know if it has 3 phalanges or 2, because I don't see it very well on the x-rays. But I would choose between those 2 for making a very nice thumb and shorten the metacarpal or take the metacarpal off. And it looks a bit easier than the other one. But if we go to the right hand, we see the 4 ulnar digits are in very, very good shape. So then again, we can choose between the 2 radial ones. So if we choose the most radial one, we know that we will have a perfect web, because we can take that finger off and make it good. If we choose the most ulnar one, the more ulnar one, we will need to do the whole flap for the first web. And there's no, I think the hands were much easier than the feet. Because,
I got
I
got the hands.
The part about the feet is that they have they just need the shape. So as long as you take most of the radial rays, three of them out, and then you need to tailor your flaps in order to have a good coverage on the plantar side. I think that's the most important part, to have a nice shape, and then the plantar skin should be all plantar, not moving the dorsal skin to the plantar side.
Yeah.
But I agree with your plan. It needs to be staged, and as in the right hand, you have two web syndactyly. That's what makes it's a game changer, because you need to stage that into surgeries.
Yep.
But well, I think your plan was perfect.
I depend. I depend. We have to think here in Colombia, or at least in my practice, we do a surgical mission every year, and we see patients through the years also. So it depends on which scenario I treat this patient. Probably because in the mission scenario, I have to try to minimize the surgical steps, and to try to do everything easier for the fathers or for the caregiver. So I think I would try to do one hand and 1 foot at a time, 1 feet at a time, probably in 2 times. I don't know. It's that way. But I agree with you. I will policize the second. Well, the fifth, the second the more radial one. Yeah.
Yeah, we were very fortunate that this is a family that lives close by, that has the means to come back repeatedly. I think that's a great point. If you encounter this child on a mission situation, that definitely changes your thinking. So I'll just just to show you some fun pictures. So started with the web release on each side. This was the hard day. You can see that the foot skin was a nice match. This is 3 months after the syndactyly release. So this is the day that we did the syndactyly release on one side, and then left this one for the last stage. And here is the policization. And again, because this was an excess situation, you can see how big of a thenar eminence she has. She had so many thenar muscles and just intrinsic muscles, muscles I'd never seen before. And then here is the last stage. And sorry, these are the photos from the overhead camera. That's why they're a little fuzzy, but here so now all the fingers are fully released, and the policization at the last stage. So, but I agree, lots of different ways you could address it. Let's see. So I think for overall congenital hand, in the best case scenario, we have a team approach. We have peer contacts that they can find families who have the similar problem to them, occupational therapy, surgery, all the principles we talked about. And this rule doesn't translate. 2 and 4 in English is kind of a play on words that this came from, again, Texas Scottish Rite, that we want to do procedures for children, not to children. So it's the 2-4 rule, but it doesn't translate well to Spanish. But you can, the principle translates well. And that's it. These are my kids. So thank you for listening to me talk about radius deficiency. Gracias.
Thank you, Andrea. One of our guests and one of our orthopedic surgeons had raised his hand. Dr. Tinoco, you want to raise your question? Are you there, Abelardo? I think, well, maybe we can have his questions in a minute. And then we're going to, we're very well time-wise, so we're gonna pass to brachial plexus. We're gonna have the two talks by Dr. Sancoli, and then we will have a short break, a 10-minute break, so that everyone can have a cup of coffee, okay? So thank you, Andrea, and thank you, Sabrina, for this first part of the course, and then we will go on to Pablo, and then we can have many more questions. Thank you.
Thank you.
Thank you, Luis. Can you see my screen?
Yeah.
Okay. Well, thank you for the invitation, Luis, Pacho. And today we will talk about brachial plexus birth palsy. And we have two talks. The first is injury patterns, and the second one will be strategies and planning for reconstruction. So the objectives of this talk will be to talk about the brachial plexus anatomy, the physical exam in these childs, and we will talk about the injury patterns. I don't have disclosures, but I want to thank my professors and my teachers in this topic, Dr. Borrero, Dr. Clifton, and Dr. Muset. And if people in the auditorium are interested, this is a brachial plexus international school program that we travel to India, Egypt, Mexico, and Barcelona in order to learn from these teachers. So birth palsy, we know that is an injury to the brachial plexus during delivery. And according to the geographic area, this can vary between 0.4 or 4 per live birth. The literature is a little bit wide. According to the recovery of this birth palsy, it can go from 66% to 92% according to the literature. And risk factors can be from the mother, like for example, diabetes, from the infant, like macrosomia, but mostly it can be from intrapartum events. So macrosomia increases the chance of birth palsy by 21%, but shoulder dystocia increase the risk of birth palsy by 76%. So the important thing is shoulder dystocia as a risk factor. Also, if the mother has a previous history of shoulder dystocia, this will increase a new shoulder dystocia by 20%. According to the anatomy, we start the brachial plexus at the medulla with the anterior rootlet and the posterior rootlet, that they will join to form the root itself, and we will have a portion of the root that will be intraforaminal with the ganglion, the dorsal ganglion root, a foraminal portion, and an extraforaminal portion of the root. And the brachial plexus itself is formed by the union of C5, C6 to form the upper trunk, C7 to form the middle trunk, and C8, T1 to form the lower trunk. Sometimes we can have contributions from C4 as a prefix brachial plexus, or from T2 as a postfix brachial plexus. So anatomy of the brachial plexus can be kind of complicated when we look at these graphs and all the innervation that the root can give, but we will try to simplify this in order to understand the brachial plexus. So really the brachial plexus has 5 roots, 3 trunks, upper, middle, and lower, 3 cords, lateral, posterior, and medial, and the terminal nerve branches, the axillary nerve, radial nerve, musculocutaneous, median, and ulnar nerve. So if we talk about C5 root, well, we know C5 root will mostly form the upper trunk and will contribute to the suprascapular nerve and to the posterior cord to form the axillary nerve to go to deltoid and teres minor. If we talk about C6, we know that it will also form the upper trunk, but in this case, C6 will contribute to the lateral cord to form the musculocutaneous nerve and go to biceps brachialis, and also give the lateral portion of the medial nerve to give sensation of C6. If we talk about C7, it will form the middle trunk, and mostly from the posterior cord, it will give the radial nerve in order to give triceps, wrist extension, and finger extension. C8, sorry, it will form the inferior trunk and will give the medial contribution to the medial nerve in order to give extrinsics of the medial nerve function. And T1 will also form the lower trunk, middle cord, and will contribute for the ulnar nerve and the intrinsics of the hand. So after reviewing the anatomy, we go to the physical exam of these babies. And Dr. Borrero always told us that the exam needs to be simple, needs to keep an order, needs to provide information for the diagnosis of the lesion, for what? To define a treatment option. So every physical exam starts with the inspection. And with the inspection, we look at the face of the children. We see if they have a horner. And also we will see the position of the extremity at rest. We will check the contour of the muscle. For example, in the right picture, we can see there's apparently a good deltoid there. And we will check if there is any atrophy. And of course, we will check how the baby plays or moves during the exam in order to check motion and the muscles. We will consider in the physical exam mostly 5 areas: the shoulder, the elbow, the wrist, the fingers, and the thumb. And the shoulder is kind of complicated in babies because the shoulder has flexion, abduction, adduction, internal rotation, and external rotation. And we all know it's kind of difficult to evaluate 1 month, 2 months, or 3 months baby, all these functions. So the shoulder is kind of complicated to evaluate really. And there are other joints more easy to evaluate, like the elbow that will be flexion and extension, the wrist also, and the fingers also flexion and extension. But really, we are not evaluating motion and of the joints. We want to evaluate the nerves because we are trying to examine a nerve injury. So the shoulder, when we look at the shoulder, we look at the axillary nerve and the suprascapular nerve. When we look to the elbow, we will look for the triceps, for the radial nerve and the musculocutaneous nerve. And also the wrist and fingers, we will look for the medial and radial nerve and also the ulnar nerve. And why we check the biceps in these babies? Well, because as we say, the shoulder has a lot of different motion, abduction, internal rotation, adduction, and it's very difficult to evaluate in an objective way this shoulder motion in a baby. So the biceps is really simple because it's just a simple motion of flexion and is a monoplanar way. If we want to evaluate really the deltoid, we will need to check only abduction at 90 degrees. So that is very difficult in the children's because they usually do anterior flexion. So we evaluate the biceps, but we need to remember we are not evaluating elbow flexion. That is a joint motion. we want to evaluate muscle contraction and the strength of this muscle. Why? Because these will have a correlation to the nerve injury and to the recovery as the nerve gets into the target and reinnervated. So when we evaluate biceps, not elbow flexion, biceps, we evaluate the musculocutaneous, the upper trunk, and C6. So for example, we see here this 3 months baby. We can do the Moro reflex. We see there's no abduction of the shoulder. We can see there's a weak triceps there, a weak triceps. There's no wrist extension. We will check the fingers also. We can see there's some atrophy there in the deltoid area. There's not a good contour. When we see a lot of atrophy, for example, in the deltoid area in a small baby like this, 2 or 3 months, we suspect of avulsion. If there's some contour, we think might be a rupture. We see there's good finger flexions. Now we check the biceps. So we try to put the forearm in supination and we put a finger over the biceps tendon and we check contraction. The contraction will be the muscle and the muscle will be a nerve into the muscle. That's what we are evaluating. And we also check finger extension and other motions while we wait the child to try to do this elbow flexion. Also, we can palpate if there is neuroma there. So we go shoulder, elbow, wrist, and fingers. Also, we check passive external rotation in adduction and in abduction. And we can score this according to Gilbert or according to Howard Clark with the active movement scale. And we will follow the child the first month, second month, 3 months, and we will follow how the contraction of the biceps and the other motion and the other muscles are improving. Do we ask complementary exams? Well, we can ask ultrasound or fluoroscopy when we have avulsions like Horner or when we have a podalic delivery, because this can be also related with injury to the phrenic nerve, and we can see an EMI diaphragm showing the injury to the phrenic nerve. Do we ask nerve conduction studies in these children? No, we don't. It has been shown that sensitivity of these nerve conduction studies are not good, and sometimes they overestimate the recovery of these children. Do we ask MRI? Well, I know they are doing some MRIs without sedation, but still here we have sedation to do MRIs. So if the child doesn't have a Horner, and depending if you are in the public system or in the private system, we can access an MRI that will give us information if there's some root avulsion, like with pseudo-meningocele. But like here we have a good C7 root, we see the anterior and posterior root, and the pseudo-meningocele here in C8. But we need to remember that 20% approximately of pseudo-meningoceles are false positive in children. The correlation of this image in adults is much better than in children. So it's really something can give you an idea on the reconstruction, but the truth will be intraoperative. So according to the injury patterns that this talk is about, we can classify burst palsy according to or the location of the injury or the type of injury. So the type of injury can be an avulsion when the root is avulsed from the central nervous system, or a rupture when the injury is extraforaminal. And according to the location, we can classify brachial plexus burst palsy injuries in upper, that this can be C5, C6 injury. These are the most common injuries. C5, C6, C7, this is an upper extended injury. This is 30% approximately of burst palsy, and lower or total injuries, and this is the 20% of the burst palsy injuries. According to the type of injury, we said that we can have an avulsion or a rupture, an injury that is inside the foramen or outside the foramen. If it is outside, we will have a root in order to graft. If it is inside, we will need to look for other options for reconstruction. And also we have a stretch injury. And we know that a stretch injury can be divided according to the Seddon or the Sunderland classification. And we see here that we can go from a neuropraxia, that will be a block in the conduction of this nerve, into axonamnesis, that we will have an injury to the axon in grade 2, an injury to the endoneuron in grade 3, or to the perineuron in grade 4, and a rupture that will be a grade 5 according to Sunderland. So neuropraxia, we will expect some recovery by 2-3 months. Axonamnesis takes more time. It will take approximately 6 months to recover. And neurodemesis, we don't expect improve at all. And of course, in avulsions, we don't expect improve at all. So why we classify according to the location these patients? Well, because it will give us a prognostic about the spontaneous recovery of this child. And as Gilbert and Naracas classify, C5, C6 can have a spontaneous recovery of 90% when we have an upper extended, and we have C7 compromised. There's a possibility of spontaneous recovery near to 65%. Of course, when we have total or when we have avulsion, the prognosis of spontaneous recovery falls. And according to the location, and the physical exam will give us the location of the injury and the type of injury. We will do a sequential physical exam in order to see what is the type of injury, if it is a neuropraxia that is getting better, or we are under a more severe injury to the nerve. So just by looking these 3 images, we can see where the injury of the brachial plexus is. If we see in the picture of the left, this child has an hyperextended elbow. And what this means? This means that the biceps is not functioning, but we have a strong triceps that is pulling against a non-functioning biceps. So in this middle photo, we have some crease at the elbow. This means that we don't have a very strong triceps and we don't have a very strong biceps. So we have a more flex position of the elbow. And here we have a Horner and a flail hand. So we can say here we have a C5, C6, and C7 will be okay with the triceps okay, pulling hard over a non-functioning biceps. Here we have a C5, C6, C7 injury. We don't have a very strong triceps. We have a wrist inflection because we don't have wrist extension. And here we have injury to the lower plexus and also an avulsion due to the Horner. So just by inspection, we can suspect the injury to the plexus and the location of the injury. Of course, we will confirm this intraoperative. So upper plexus injuries, what we will have a bad shoulder. We won't have a deltoid. We don't have elbow flexion, but we will have a very good hand. And here we check a good triceps. We will check if there is any biceps. Remember, we need to palpate the biceps. We don't want to see only motion. We want to see contraction, muscle contraction. That means the reinnervation of the muscle. So we say upper C5, C6, we will have a bad shoulder. We won't have abduction. We won't have external rotation, but the arm will be in normal adduction and normal internal rotation. So we usually see these children with their arm against the thorax, internal rotated, as we see in this picture. And we will have also a bad elbow. And in this case, with C5, C6 injury, the elbow will be in full extension because we don't have biceps, but we have a pulling triceps. So the elbow goes into full extension. The wrist usually is normal and the fingers are normal. So C5, C6, bad shoulder, bad elbow flexion, and a very good hand. And we can see here the physical exam. So this is Ian. We see a good wrist, good finger extension, good finger flexion, good wrist flexion. The thumb also have good flexion. We try to palpate these biceps to feel the contraction. And when we palpate the biceps, we are evaluating the musculocutaneous, the upper trunk, C6. So when we have an upper extended injury, we know that there's worse prognosis for spontaneous recovery. Also, we have a bad shoulder, a bad elbow flexion, and a good hand. But the difference with the previous one is that we have the elbow in partial flexion. We have a little crease there, and this is because we don't have biceps and we don't have a good triceps. We can have some weak triceps, maybe M2 according to Gilbert, or no triceps at all. So that's why we have this different position of the extremity. And C7 has a lot of anatomic variations. So usually we can have loss of wrist extension, finger extension, and some extension, but we will have a very good wrist and finger flexion. That's the reason why we see a normal wrist flexion, fingers and thumb, and an exaggerated wrist flexion, because we don't have a good C7 extending the wrist. So there's an opposite wrist flexion, and the patient will have the typical position of internal rotated shoulder, extended partially elbow, pronated forearm, and the wrist in unopposed flexion, what is called the Porter tips stance, as we see here in the picture. And we can see here the physical exam of this baby again. No good wrist extension and a kind of weak triceps. And the rest position of the extremity won't be in complete extension of the elbow. So the other location or the other type of location of birth palsy injuries are the lower and total. And we said that we look at the face and we can see a Horner, and we will have in these cases a bad hand and some shoulder function, especially if the baby is more grow. They will kind of some anterior flexion of the shoulder. So in these babies, we have a completely flail extremity. We won't have triceps, biceps, wrist extension, wrist flexion. We won't have any finger flexions. Sometimes we can see some trophic changes in the hand, or if they are bigger, they bite the fingers. So they have a very bad hand and maybe some shoulder. So a flail, insensate limb. And if we have a Horner, of course, we are talking about a worse prognosis because it's correlated with avulsions of the roots. So these total lower injuries, we know they are very severe injuries, and waiting will result in an extremity with severe limitations, according to Gilbert and the literature. So in conclusion, for this first talk, we can classify injury patterns according to the location. Into upper, we will have a bad shoulder, no elbow flexion, but a very good hand. If it is extended, we will have some kind of crease at the elbow because we don't have a very good triceps also. We have lower injuries, lower total, that will have some shoulder, but a very bad hand and a complete flail extremity, as we see here. Or according to the type of nerve injury, we can have a stretch, rupture, or avulsion injury, that we will divide this according to the Sunderland classification. Thank you very much. This is the hospital in Buenos Aires, Ricardo Gutierrez, where we see these children. Let me stop sharing. I don't know if there's any question or we continue with the next talk.
I think we can go on, and then because we're really fine about time. So
okay,
there was a question that Sabrina already answered, and we will have a discussion later. So please go on, Pablo.
Perfect, thank you. So let me share again. So the second talk is about surgical indications and planning. And the objectives of this talk will be to talk about, review the patterns of injury patterns, and we will talk about surgical indications and planning according to the injury. So again, the disclosure to my professors. So we said that in upper injuries, we have a good hand, but we don't have elbow flexion, and we have a bad shoulder. So what we know according to the literature for these upper injuries, well, we know that if we have a biceps partial anti-gravitatory muscle strength, in the first 2 months, we will have a full recovery of this kid, of this baby by 2 years old. And if the biceps recover after 3 months, there will be strength and range of motion limitations. And after 3 months of recovery of the shoulder, we know that the global shoulder function worsens with increasing delay in the return of bicep function. So if there is no biceps by 3 months, according to Gilbert, this is related to poor shoulder outcomes. Sorry, I write wrong there. Poor shoulder outcomes at 5 years old. And there's an increase of secondary procedures at the shoulder if the biceps doesn't come by 3 months. And also we know that we will get worst mallet scores in patients who recover biceps after 6 months than if they recover the biceps between 4 and 6 months. So what we know is that the more time the biceps takes to recover, the worse the shoulder will be. And there's a lot of literature talking about when is the correct time to do surgery in these kids and according to the biceps recovery. But we can mostly divide all this literature into 3 groups. If we don't have biceps, according to Gilbert, at 3 months, we will do surgery. If we don't have biceps between 4 and 6 months, according to, for example, Al-Katan, we will do surgery. Or if we don't have biceps by 9 months, we will do surgery according to the cookie test of Howard Clark. So mostly we can divide the literature into three different groups: 3 months, 4 to 6, or 9 months, into go to conservative or microsurgical reconstruction. But the truth is that the correct timing is unknown when to do surgery according to the biceps recovery. But the important thing is that it's not the biceps the important thing that needs to recover. The important thing in Bird's palsy is the shoulder, because the more time the biceps takes to recover, the more complications we have with the shoulder. And then we start treating all the secondary procedures for the shoulder: internal rotation contracture and deformity of the glena and subluxation. So as Christophe Overland said, the urgency in OBP is to avoid shoulder deformity. And we know that the more time it takes the bicep to come, the more complications we have at the shoulder. That's the reason why we like to perform surgery near to the 3 months is possible if we don't have any biceps according to our school. So if we don't have biceps, as we see here, if we don't have biceps, we are talking 0 biceps by 3 to 9 months according to the different schools, we will go to surgery. And why? Well, because surgery will allow us to do a brachial plexus exploration to make a diagnosis of the lesion. And this will give us the opportunity to use an available route. And this is the advantage over nerve transfers. With the route, we can restore more functions than only with nerve transfers. We are talking also about sensation in the extremity. So in upper and C6 lesions, we will have a bad shoulder. We don't have abduction. This means we don't have deltoid and supraspinatus. We don't have external rotation. This means we don't have teres minor and infraspinatus. And this means our targets needs to be the axillary nerve and the suprascapular nerve. We have also a bad elbow. We don't have flexion at the elbow. This means we don't have biceps. We don't have brachialis. So we know that our target needs to be the musculocutaneous. So the strategies in upper birth palsies needs to be tailored to every patient. We cannot do like one thing to everyone. Every patient is different, the context, the age, and the type of injury. So every injury needs to be tailored, but we can give a general idea what we do. So when we have an upper C5, C6 injury, and during the exploration, we have 2 routes available. This means extraforaminal or post-ganglionic injury to C5 and C6. Well, we have the opportunity to use these routes as donor of axons to reconstruct the function. So what we do? Well, we can do spinal accessory to suprascapular nerve in order to restore supra and infraspinatus. We will use the best route available to go to the posterior division of the upper trunk for what? To restore the shoulder. We said that the shoulder is the principal complication in these childs with upper injuries. So with the best route, we go to the posterior division of the upper trunk to reinnervate the axillary nerve, to reinnervate deltoid and teres minor. And the second route, we go to the anterior division of the upper trunk. In that way, we will give sensation to C6. So, and also we can do an overland. This is passing the FCU fascicle to the biceps. So in this way, we attack the elbow by 2 different ways: nerve transfer and from the root, and the shoulder from the root and from the spinal accessory, also from nerve transfers. So yesterday I was thinking and I put 2 to 1. This means 2 different paths to reinnervate one function. One from nerve transfer, one from the root. And I believe if we attack one function with 2 different ways, we have a chance to obtain a better result. So for the shoulder and the elbow, we attack the function and the muscles with the roots and the nerve transfers. Also the advantage of reinnervating with the root the upper division of the upper trunk is that we will reinnervate coracobrachialis, the brachialis, brachioradialis, the supinator, and sensation from C6. This is something that a simple overland won't do. So what happens when we have one root available? Well, we try to do this 2 to 1 pathway for the shoulder. We will do spinal accessory to suprascapular for reinnervating supra and infraspinatus. And we will use this good root to go to the posterior division of the upper trunk. So the grafts will reinnervate the axillary nerve. So we reinnervate deltoid and teres minor. And we will do an overland for elbow flexion. And this is what we do. If we can do also one graft to the anterior division in order to give a sensation. So we use, if we only have one root, we will go to the posterior division of the upper trunk. The upper trunk is a trifurcation where we have the suprascapular, posterior division, and upper division. We will go to the posterior division that this will go to the shoulder. And we do an overland to restore elbow flexion. And this is what we do. We get the grafts, we use the best route, the only route to go to the posterior division, spinal accessory to suprascapular, and an overland. What happens if we don't have any root in this C5, C6? Well, of course, here we don't have any root to graft, so we will go into nerve transfers. Also, if this child is near 1 year old or past 1 year old, we will go also to nerve transfers in order to be near the target and reinnervate these muscles. And we will do spinal accessory to suprascapular nerve. We will use the triceps brand for axillary nerve. This can be done through a posterior approach or through an axillary approach. And we will do an overland for elbow flexion. If we have C5, C6, C7, well, if we have all the roots, we can reconstruct all the functions with grafts. And we can add an overland if we want in order to obtain a second attack to elbow flexion. And this is a case I want to comment. I believe it's interesting and I learned a lot from this case. So this baby that we saw the video previously, she had a C5. We said previously that she had a lot of atrophy and really she had an avulsion of C5. So when we see a lot of atrophy, we tend to think that they can have an avulsion there. Because nothing is passing through the neuroma and there's no bulky muscle at all. So this child, this baby, she had a C5, C6 avulsion and a neuroma in C7. This is what we find intraoperative. And she had a weak tricep. So at the time of surgery, I did a spinal accessory to suprascapular, and C7 had a lot of neuroma, so I did a neurolysis and it was conducting. So I just did a neurolysis of C7 and I did an overland at the same time. So I thought, well, once I recover a good tricep, I can go and do a triceps to branch to axillary. And that is what we did. We did surgery in this baby at 3 months. She didn't have any biceps and atrophy of the deltoid. She had a lot. She had C5, C6 avulsion and a neuroma in C7. After the neurolysis at 7 months, she had a strong triceps and strong wrist extension, so that maybe help for C7. And we did the triceps branch to axillary. And this is the result 1 year later after the first surgery. We have a good biceps function with the orbital line, and we have good deltoid, also an external rotation function. We are missing some extension here. We need to work in abduction and extension of the elbow. But that is what we did. And I thought a lot about what I could do at that time in the first surgery. So I called Dr. Borrero and he told me, Pablo, you forgot in the first surgery to use the posterior cord. Why? Because in the posterior cord, if I go infraclavicular, I could go to the posterior cord and I could check subscapularis branch and thoracodorsal branch, and I could have done this transfer in the first surgery. So that is something I learned. So in C5, C6, and avulsion and C7 that we don't have a very good tricep, we can go infraclavicular and check the branches of the posterior cord, subscapular and thoracodorsal, and pass their nerve transfer in the same time. So there's my teacher giving me a good punch and a good teaching. In lower injuries, of course, we know the worst prognosis in these injuries is present, and we don't have any hand at all function. We can have some shoulder flexion according to the age of the patient that will be compensatory, maybe from some pectoral recovery, coracobrachyialis. But what we do? Well, these patients, they have a complete flail extremity, insensate limbs, they are severe injuries, and waiting will result in extremity limitations, according to Gilbert and his follow-ups. So if there's no significant recovery of the hand with the first, we will say 3 months, is an indication to do surgery, especially also if they have a Horner. And surgery will define the lesion, will maximize the time for recovery because we will have more time in order to renervate the hand if we go for surgery quick at 3 months, minimizing the motor end plate loss that we know in adults is lost at 18 months more or less, but in children we really don't know when we lose completely the motor end plate. So we need to give a chance to that hand and go and try to reconstruct it. And the literature tells us that the hand in children can be renervated. That's the reason why the primary goal in total OBP's injuries is to restore hand function. And this is completely different to the adults. So in children, if we have a total injury or avulsion of the lower trunk, we can go and try to neurotize that trunk and get renervation of the hand. So what are the reconstruction priorities in these lower and total injuries? Well, first, as we said, we have a chance to renervate the hand. So we need to go to the lower trunk. That's our first priority. Our second priority will be elbow flexion. So we try to give function to that biceps and brachialis from the musculocutaneous. And the third reconstructed priority will be the shoulder. So we will go to the posterior division of the upper trunk and suprascapular nerve. So again, every patient and every injury needs to be tailored, but in order to give kind of a guideline of what is the idea of the Brachial Plexus International School, if we have two routes available in these total injuries, well, we said we can go and renervate the hand, so we will use the best route that we find macroscopic during the surgery to go to the lower trunk. And we will go with intercostals for elbow flexion. And we will use the second best route for shoulder. This means a posterior division of the upper trunk, and we will do spinal accessory to suprascapular nerve. If we have only one route available, like this drawing, well, we will use that route to go to the hand. So we will use that route to graft the lower trunk. We will go with intercostals for elbow flexion, and we will stabilize the shoulder with spinal accessory to suprascapular. Dr. Musset, one of the teachers in the school, he gives a lot of importance of reconstructing the shoulder. So in these cases, he told me he will use contralateral C7 with grafts to the posterior division of the upper trunk in order to renervate that shoulder and give the best function to these childs. If we have no route available, this means complete five root avulsion is a strength scenario. Well, we will use contralateral C7 with grafts to lower trunk, intercostals to elbow flexion, and spinal accessory to suprascapular nerve. So in conclusion, we use the biceps because the biceps correlates with a nerve injury. We need to check the strength of the biceps. We are not evaluating joint motion, not elbow flexion. We are evaluating a muscle, and a muscle correlates with a nerve, and the nerve correlates with the injury. And we know the later the biceps recover, the worse the shoulder outcomes will be, and the children will probably need secondary surgeries to correct the deformities and the sequela the shoulder gets. So the literature talks about going to surgery, microsurgical reconstruction, if we don't have biceps between 3 and 9 months to indicate a reconstruction of the brachial plexus. But really the correct timing is unknown. Strategies need to be tailored to each patient, to each lesion, and to what we find intraoperative. Exploration of the brachial plexus is very, very important, not to go only for nerve transfers, because these will give us available routes to reconstruct more functions. If possible, we can use 2-to-1. This means 2 paths to renervate one function, use the roots and the nerve transfer to renervate only one function. Do the overland and go with the graft to the anterior division of the upper trunk to renervate brachialis from the roots and the biceps from the nerve transfer. In total injuries, the priority is to renervate the hand. This is possible in children, and we need to give these children a chance. So this is the talk, and thank you very much to Dr. Varone, the Chief of Upper Extremity in the Hospital Gutiérrez in Buenos Aires. Thank you.
Thank you, Pablo. Great talks. We really enjoyed it. And I think it was very, very illustrative. We have one question right now from the audience. I lost it. Well, the question was, if the patient has a flexion, shoulder flexion recovery, but there is no external rotation, when do you address it surgically? Do you go for some exploration? What do you do with that?
So the child has elbow Shoulder and elbow.
Yeah. And
So
no external rotation.
Okay, so at that time, you have the chance, Dr. Soldado has, if you have a good joint and you don't have any contractor, internal rotation contractor, because if not, you need to release the contractor, but there's a chance for nerve surgery. There's a neurotization of the teres minor that this can be done with a branch of the triceps, and he also does a spinal accessory to infraspinatus. So a selective neurotization for external rotations, and after approximately 18 months.
Right.
But we need to have a free joint for this.
Yeah. How young have you found patients to have external rotation limitation? Because when you see I don't know, when I see a patient who is 9 months old, I'm thinking about the external rotation limitation, but sometimes you may not be aware of that in a younger child. For example, there are some which are already limited when they are 3 months old. So how young do you see the patients, and when do you start addressing that?
Yeah, that's completely true. The internal rotation contractor, I believe it has to have the imbalance probably, but it's not only that. Probably there's some trauma during the delivery that also injures the muscle. Scaglietti long time ago talked about that, and there can be some contraction of the muscle itself, contractura myostatica. So we can have contraction, internal contraction, even in small child, 3 months, 4 months, where still we don't have the time to do the imbalance of the muscle. So I believe it has some relation to also the trauma in the delivery. When we start to address it, well, we start to address, that's the worst problem is the shoulder. So as soon as we see a child with burst palsy, we talk to the mother that will be the person that will be all the time with the child, that every time she changes the diapers to do the exercises in A deduction, external rotation, AB duction, external rotation, to avoid this contracture. If they are starting to have contraction, also with the physical therapy, and the mother will start working with it. And we wait. And if we don't have this bicep, we try to be a little bit more aggressive. We try to be like the Gilbert school. That's what we learn with the group of Mielina, Dr. Borrero, also Moset, because the importance is not the biceps for us, it's not the elbow flexion, it's the shoulder. And the more time we take to reconstruct the plexus, the more problems we have to shoulder, and then we need to do reconstruction of the glenoid and releases and everything. And also we have more co-contraction because we have an neuroma, we have renervation through a neuroma, we have co-contraction of the shoulder, so the child is kind of making elbow flexion, anterior flexion of the shoulder, and the co-contraction, and it's difficult to rehab all these problems.
Great answer. Thank you. I learned. I think we have no more questions right now, so I propose to go to a 10-minute break, and then it is, what time is it now? 10 o'clock. So we will restart at 10:10 with the next talks, and then we will have a nice discussion. Thank you, Pablo. See you in 10 minutes.
Bye.
Pablo, apaga tu pantalla, por favor.
Sí. A ver. ¿Cómo hago?
Dejar de compartir.
Voy a tratar de salir.
Abajo, compartir pantalla, dice, entonces dejas de compartir.
Stop share. Ahí está.
Perfecto.
Perdón, no sé usar mucho esto, Luis.
Hola Javeriano, te saludo desde casa, a ti y a toda la familia. Tal vez hoy los salones no están llenos, no compartimos el hueco juntos. Tal vez no nos veremos en algunos días, pero estoy seguro de una cosa. Hoy estamos más unidos que nunca. Este es un tiempo para estar en casa, cuidar de nuestras familias y estrechar el vínculo que como amigos hemos construido. Seguro nos volveremos a encontrar. Superaremos juntos esta prueba. El campus universitario nos espera. Sin nosotros, sin la... Hola Javeriano, te saludo desde casa, a ti y a... Hola Javeriano, te saludo desde casa, a ti y a toda la familia. Tal vez hoy los salones no están llenos, no compartimos el hueco juntos. Tal vez no nos veremos en algunos días, pero estoy seguro de una cosa. Hoy estamos más unidos que nunca. Este es un tiempo para estar en casa, cuidar de nuestras familias y estrechar el vínculo que como amigos hemos construido. Seguro nos volveremos a encontrar. Superaremos juntos esta prueba. El campus universitario nos espera. Sin nosotros, sin la comunidad javeriana, no son más que edificaciones. Por último, solo quiero pedirte una cosa. Quédate en casa. Por ti y por el planeta, por sus habitantes, por aquel javeriano que deseas volver a ver. Estos días no serán más que un buen recuerdo de lo que juntos logramos construir en la distancia. Hola Javeriano, te saludo desde casa, a ti y a toda la familia. Tal vez hoy los salones no están llenos, no compartimos el...
Okay, we're back. Is everyone around? We are going to continue with Dr. Bauer's conference on the treatment in children older than 1 year old.
Great, thank you.
Okay.
Let's All right, welcome back to everyone. Dr. Zancoli started with some of the talk on nerve transfers. I think very salient points that nerve transfers, we do lose out on some things in terms of, only being able to target certain muscles. I thought those were some great points in his talk. So I will just focus mostly on the nerve treatment over a year of age, and then Dr. Gallego will continue with talking more about the shoulder. Some of the work that I will talk about in this talk, as well as in my other brachial plexus talk, is the result of some grant-funded research. And then, as with all of us, all of this work is only possible with all of my teammates. The first thing I want to talk about is this small research project looking at the outcome of late microsurgical nerve reconstruction in brachial plexus birth injury. And so as Dr. Zancoli talked about, nerve surgery is recommended usually between 3 and 9 months of life. But sometimes infants undergo surgery late. This can be because they presented late, because there's a surgical delay. Certainly that may be happening right now as we deal with this worldwide pandemic. And then there are also some unusual patterns of recovery in which we may not necessarily indicate someone for surgery in the beginning and then later change our minds. So the questions for this project were, if we take infants who are over 9 months of age, does our nerve surgery work? Do our active movement scale scores improve after surgery? The active movement scale, as many of you know, is a motor assessment of the upper extremity developed at the Hospital for Sick Kids in Toronto, basically examining all of the muscles of the upper extremity on a 0 to 7 scale because we can't test MRC or strength in babies. And then our secondary question was, okay, if these AMS scores do improve, are the postoperative scores different in the groups who underwent nerve transfers or nerve graft? When you get to an older age, are the nerve transfers better? This came from, as part of the TOBY collaboration in the US. There are 6 centers that have enrolled 750 infants in this study. And from that, we were able to come up with 32 who underwent late surgery after 9 months of age that had a minimum of a year follow-up after surgery. And again, this is just the description in this table of the AMS score for anyone who is not familiar with how that's graded. It's a 0 to 7 scale. And I think it's also important to note that we looked at these scores prior to any secondary surgery. And so obviously with brachial plexus injury, many children undergo staged surgeries, later tendon transfers. This was trying to assess just the results of the nerve surgery. In this group, we had 25 upper trunk injuries and 7 global injuries. So even global injuries undergoing surgery after the age of 9 months of age. And the mean age at microsurgery was 12 months of age. The reasons for why children were operated on late, so about a quarter of them just presented late, 12% were lost to follow-up, 21% had a delayed surgical date, 21% had an unusual recovery pattern such that we changed our minds, initially thought they did not need surgery and then changed course. And then about a third of them were addressing that question about what to do when you have an isolated external rotation deficit. And these were children that had an isolated spinal accessory to suprascapular transfer. And if we look at our total AMS scores, they improved over time. And so this was, even in this small group, statistically significant. And I think an important sort of basic question to ask as we get, as we know from our adult surgery, you can get far enough from an injury that nerve surgery will no longer be helpful. But in this case, in these infants at a mean age of a year, they did have improvements in motor function after surgery. When we look at transfers versus grafts, we did see a slight improvement in the total AMS scores in those infants who underwent nerve transfers as opposed to grafts, but it was only statistically significant at 1 year. And so this may simply be showing us that the nerve transfers work a bit faster than the grafts because of the location of the surgery, but they may not actually be, they may not in the end be better. And this was the group that underwent the isolated spinal accessory to suprascapular nerve transfer. This graph is showing only the shoulder external rotation AMS score on a scale from 0 to 10, showing that these children continued to show improvement at 2 years and even 3 years after surgery without any tendon transfer surgery, just from the results of this nerve transfer. And so what this little study helped us to cement is that indeed nerve surgery done after 9 months of age can lead to improved function. It's possible that transfers in this older group are superior to grafting, and I think that that is an area that definitely needs more rigorous study. This was a retrospective multi-center study. I think more of a prospective and even randomized study could be considered for that question. And that ultimately it's okay to do nerve reconstruction after 9 months of age. So if you're in that mission sort of situation where a child presents late to you, even with a global injury, you can make some improvement by doing the nerve surgery in those older babies. And so I just wanted to touch briefly on the nerve transfers that we do, and these are just the this is just the basics. Some of the and so I'll go through the three popular, the so-called triple transfers for upper trunk injuries. And just as a review, we need an expendable, healthy, robust donor. It helps when it's synergistic. And the recipient still needs to be viable and have an intact neuromuscular junction. Those things are fortunately usually in our favor with a brachial plexus injury in a baby, that we don't need to worry about the recipient muscle. And as Dr. Zancoli mentioned earlier, the donor has to be healthy enough by the time of surgery. So even a donor that was previously injured but has now recovered is possible to be used. I think that the success of the Oberlin transfer is really what has started this field. And so, as you all know, this was originally described as a nerve transfer to the biceps muscle using a single fascicle from the ulnar nerve, published in 1994 initially, and has been a bit expanded to include intravesicular dissection of the median or the ulnar nerve. And really, I think because this transfer was so good is what has made us go searching for all of the other transfers that are possible. These are just some examples of how this might be done. In a baby, here you can see set up for an Oberlin transfer with an incision that could be combined to harvest intercostal nerves if necessary. And here, hopefully this will load. So here, a medial arm incision directly over the biceps. You can see the motor branch to the biceps there being isolated. And it's important that that comes in up under the biceps to go. You need to be looking for that underneath the muscle belly of the biceps. And you can see there the continuation of the musculocutaneous nerve going down into the lateral interbrachial cutaneous that obviously you don't want to be plugging into. Here, the brachial artery is protected, and there's the median nerve and the ulnar nerve isolated. Either one can be used. Intravesicular dissection helps us to pick a fascicle, and our preference is to always use electrical stimulation to confirm not only that we've selected an extrinsic fascicle, but also that we're leaving behind sufficient intrinsic fascicles to protect the hand. So there the fascicle is selected. We have a recipient. We follow Dr. McKinnon's mantra of recipient proximal and donor distal, and then coaptation with fibrin glue. And And the results of the Oberlin have really been fantastic. And why is that? So if we think about axon count, the median nerve and the ulnar nerve are very smart nerves. They're dense with motor fascicles, with motor axons. And so the axon count in the biceps and the brachialis in those entire motor nerves is the same as one fascicle of the median or ulnar nerve. In addition, there's the synergistic effect of, not quite synergy, but the Steinler effect of flexing the wrist and fingers along with the elbow. And so there are many reasons why this is a good transfer. Complications in terms of loss of intrinsic nerve function are fortunately rare, although they have been reported. So then I think the second most popular one perhaps is the SAMSOC transfer, or the partial radial to axillary transfer. And this was initially described for the long head of the triceps as the donor, based on how the tricep is used as a free muscle donor, where we typically take the long head. There have been many modifications since then. And you can see here from the axon counts, perhaps why this is not as good of a transfer. And so there are 4,000 axons in just the anterior branch of the axillary nerve, but only about 2,000 in a triceps branch. And so this is why we need to work hard to exclude branches from the axillary nerve if we're going to perform this transfer. And so here's just an intraoperative dissection and coaptation. One thing that can be helpful in babies that we wrote up a technique for in the Journal of Hand Surgery is the anterior approach. And so here, so the arm is going out this way, the baby's head is up here, but you can see through this axillary incision, we can get to both the Oberlin transfer as well as the radial to axillary transfer from the front. This is not a great idea probably in big muscly adults, but in young children, you can easily kind of move everything aside and get all the way into the axilla and into that branch point of the axillary nerve from an anterior approach without having to switch positions. And here you can see the ability to then dissect out. So here, you can target just the anterior division, dissecting away the posterior division and the teres branch. And then finally, the spinal accessory to suprascapular transfer, as Dr. Zancoli mentioned. My preference generally is to do this through the front, as you can see in this picture. We can then do any transfer that's necessary, including a brachial plexus exploration, all in the supine position, which I think our anesthesiologists prefer. And again, perhaps why we have so much difficulty with the spinal accessory transfer is there's an even greater axon mismatch between these two nerves. This has also been described from the back. And here you can see an illustration from Dr. McKinnon demonstrating finding the transfer from the back and how this could be combined with a radial to axillary transfer in the back. There's just some pictures of the posterior approach to it. But again, many different ways to approach all of these transfers depending on the combinations that you need for your particular patient. And then lastly, I just threw this in here. I wanted to mention this. This is not something that the contralateral C7, I think, is something that has been popularized more recently. But not something that I think is a routine part of, certainly not routine, and not something that really has much of a role in our practice, aside from perhaps the very rare cases of 5-root avulsions. And just looking in general at nerve transfers, so this was a study, again, from the Toby centers, where we looked at the reconstruction of the suprascapular nerve, whether that was done with grafts or transfers. And we found that in the children who received a transfer from the spinal accessory nerve, there were a greater proportion of those that reached a functional AMS score, so a 6 or 7 on the AMS scale, and a lower proportion of them that eventually needed a secondary shoulder surgery to improve their external rotation. As with much of brachial plexus surgery, the results here are not overwhelming in terms of our improvement, but I think there are a couple of ways in which the nerve transfers perhaps give us an edge. And I think, so I think in summary, nerve reconstruction is definitely still possible after age 1, and when your surgeries are delayed because of COVID or other reasons, when patients present late, I think that it's still a very viable option that we should offer. This is the indication where I might think more strongly about nerve transfers. Although I agree with Dr. Zancoli on the benefits of nerve grafting, in these older babies, I might be more likely to offer the so-called triple transfer of the Oberlin, SAMSOC, and SAN to spinal to suprascapular nerve transfer. And just wanted to throw out the technical pearl of considering the anterior approach in babies for the radial to axillary transfers so that you can combine everything from the front. Any questions?
Not right now. I think we can go on with Dr. Gallego's talk, and then I have several questions for all of you. So, but I think we can take them all together.
Thank you.
So, please, Sabrina, take the stand.
Yes, I'm starting. So, wait. I cannot put the, wait. This is.
The mouse is.
Yeah, you know, no, now I can, okay. So thank you again for inviting me. I know you're tired probably, and this has been a long journey, but I think a good one. So the leg reconstruction and salvage procedures of the brachial plexus lesions in adults or in children are a huge subject. But as my previous speaker said, we are going to focus on the shoulder. Why? Because this is one of the most important sequela in those children. Even when we operate them or not, or even if they recover most of the times, as literature says. So now that Pablo talked about that, the incidence is 0.4 to 4 per million lived births. And according to records, between 60 and 90% of the cases are mild with complete recovery if they recover before 2 months of age. So we have to see this in a bigger picture. So 10 to 15% of patients can preserve with or can stay with permanent weakness and some sequela of it. Almost 75 or 76% of these cases are the from the upper roots. And the importance of it is, as they all say, that the shoulder is like I think it's a complicated joint with a lot of muscle, a lot of movements, a lot of learning during growth. So if you don't have a good recovery in the elbow by 2 months of age, we can predict that it's going to be necessary to do some late procedures after. Even if the elbow recovers, the hand is good, or you have any improvement in the abduction, mostly in the shoulder. But if we have some persistent weakness of these in these patients, 35% of these patients with any weakness are going to present weakness, also contracture and articular deformity, and that's the most important thing we have to address today. So when we have delayed recovery, they say after 3 months of life, 60 to 80% of these kids are going to have any degree of glenohumeral dysplasia. That's important because that guides our treatment. And another thing that is important to know is that 2/3 of these patients are going to be dysplastic by 2 years of age. So we have to act quickly. Why? Because If we have a deficit of internal rotation and abduction, we have a muscle imbalance because we mostly in patients with partial pulses, not in global, or at least not as severe as in partial patients. There's going to be a muscle imbalance because the internal rotators are still innervated and they pull toward internal rotation. So it's going to cause a muscle contracture of these internal rotators, and not only the rotators, but also the articular capsule of the glenohumeral joint. And muscle atrophy of the external rotators and the abductors. So this is going to play as a non equal pull on the posterior part of the joint, going to generate a posterior instability. And this is a severe case, probably most of the severe that I've seen. Normally, this is the glen, this is the humeral head, and we see that it's completely luxated posteriorly. So it's going to give us this difficult sequela to treat with a patient that can not move very well, and cannot use her extremity even as an adjunct. So examination is difficult, as they all said previously, but I want to show you here that sometimes posterior dislocation can be seen more easily when patients are under general anesthesia. This is the same patient we saw before, and we can see clearly the posterior dislocation she has. I'm not going to take a lot of time talking about this, probably not showing you the technical aspects of the procedures, of the transfers or the procedures itself, but I want you to be with this triangle, or this decision-making strategy. So there's three things that we have to take in count. One is patient age. One is the likelihood of neurological recovery, because if patients were operated, or if they are small and they still have any potential for neurological recovery, it's going to change our decision. And most important, the glenohumeral joint stress, as I told you before. So the evaluation, this is the Waters classification for the glenoid deformity or the shoulder deformity. There are a lot of them outside. You can use whatever you feel comfortable or can do easily, but I recommend you to do it before and after surgery. Otherwise, you're not going to see how your results, if your results are good or not. There's also the Mallet score. This is a more practical or more easy to make. And it can be correlated functionally. So evaluation of these patients is mainly by clinical exam. We don't usually to see how muscles are functioning. We don't usually do electrodiagnostic studies, but for screening for dislocation, it is used the ultrasound lately. There are some radiologists that are experienced in musculoskeletal ultrasound. I have not a lot of experience with that, but I know the people who can do it. But the most important exam to plan surgical treatment is MRI, because it's going to give us the exact anatomy of the glena, and it's going to help us to reconstruct the shoulder. So then you are going to decide you're going to treat your patient. Sometimes you can treat it by not conservatively. The conservative treatment includes physiotherapy, splinting in a spica cast, in external rotation and abduction. and sometimes concomitant use of botulinum toxin. It has been proved better results than only put the toxin or only splinting, because it's going to prevent contraction. So surgical indications are posterior dislocation, as we saw on the patient, a persistent contracture in spite of every conservative treatment, physiotherapy, the plateau of nerve recovery. We're not expecting more recovery, so we have to do something. Clinical absence of abduction and or external rotation. And if you see a progressive deformity, it's going to be a red signal to go to the operating room too. Here, there's like a roadmap to choice what you have to do with these patients. Again, the glenohumeral joint is the most important, let's say, anatomic feature that we have to know before the surgery, and we have to know if it's dysplasic. Normally they are dysplasic, as we told before, but they are less or mild dysplasic, so it changes a little bit, because when the glena is not too much, has not too much dysplasia, we probably can get better results using only procedures that are not intra-articular, so release of muscular contracture and tendon transfers when there are weak external rotations. So if you have a dysplasic joint, a more dysplasic joint, you have to ask yourself if there's remodeling potential. If not, because of the age, because of the clinical exam you made in the patient, because of the results of your MRI, you sometimes have to think about doing a glenodosteotomy, although it is not too much in use and there's not long follow-up on this. But also you can choose a humeral osteotomy. That can be good, especially in older patients who present late 2 years of age, because normally when there's 2 or more years, there's a lot of patients that already have a cerebral ingrama and they are not going to learn how to use efficiently these transfers. Sometimes they do, because they're kids and there's cerebral plasticity, but we know that if we treat these patients before 2 or 3 years of age, they're going to do better, even though they are all going to have any form of recovery. If you think that the joint has any remodeling potential, you can do articular reconstruction, and you have to use open or arthroscopic reconstruction, basically reduction of dislocation and capsular release. So I am going to show you some cases. It was a patient that I knew when he was 4 years old. He presented with these clinical features. Then he grew up. Sometimes the social service here is not as good, and we have the patients at 1 year and we see them again 2 years or 1 or 2 years after. And this patient was operated as a part of a mission that I told you before. And it was, they do a capsular anterior release and a tendon transfer of the latissimus dorsi. You see, he has some improvement in his abduction. He has not to use the entire thorax to get to the bottle or to go to get the arm up like he did before. Look at that. He's better now, but the results are not as good as we want because he is older than we wanted to be. Look at the abduction. And he has some external rotation. He has good hand-to-mouth pattern. We'll see it later there. But he has not the best hand to head pattern. This is the same patient I showed you before. It was risky to take her to the operating room, but she has no useful movement of her extremity. So we did an anterior release. You can see here in the shoulder the scar. She improved the position of the arm. She improved the external rotation and the head to mouth and head to hand to mouth and hand to head patterns, but still lacking some good movement and some abduction. She went after into nerve graft from the suralis muscle in order to provide her with a free functional muscular transfer for hand reconstruction. This is another patient. We knew her when she was 1 month old. She recovered like around 6 months of age, but she didn't recover the external rotation. So we underwent to do a posterior approach to the suprascapular nerve, to the spinal accessory to the suprascapular nerve, and she improves a little bit, but not all that we wanted. So after that, now she's 5, and she's here 2 months post-operatively after capsular anterior release and latissimus dorsi transfer. Then we went into, I think, tendon transfer for extension of her wrist and fingers. This is her and how she functions better. So in conclusion, we have to know how our glenoid, our joint is, and after we decide how it is and what are we going to do, we have to do it well, because most of 80% of patients are going to have an improvement on her shoulder function, even though it's not the perfect function, but it is a useful and good function. For elbow reanimation, there's a topic that we don't talk too much because there's more strange, more rare than shoulder sequela. Gilbert says that less of 4% of patients have a complete absence of flexion. We see this child here. She's not complete without elbow flexion, but it is too difficult for her to flex her elbow that we have to do something for her. The more frequent we see is weakness, and normally with regional tendon transfers, we can get some improvement. In this child, we did a triceps tendon transfer because we saw in the clinical examination that she has co-contractions with triceps. So we think about probably use these co-contractions from partial recovery, and she get a good recovery elbow flexion. There are several options depending on the residual function of each patient. There is the pectoralis, major and minor, for total or for improvement the force of weakness. They're difficult because the scar, especially in girls, is not too good. And you have to use sometimes a tendon graft or allograft or facial allograft. So it's not not much surgeons use it. The other one is the latissimus dorsi. The latissimus dorsi is a good muscle. It has a strength. It gives good elbow flexion. But the problem is if we have a children with shoulder sequela and flexion sequela, we prefer to use the latissimus dorsi to make improvement of the shoulder. Because although there's another transfers that have been used in shoulder abduction and external rotation, like the trapezius, the multiple fascicles of the trapezius, I think in my experience, they're not as good as the latissimus dorsi, or they're not as good as they are in adults, like in children. Also, we have the Steindler procedure, that is the transfer of the muscle pronator flexor mass of the medial epicondyle. And this is the preferred transfer that Gilbert does when it's available. I'm gonna show you here some video from that transfer. This is done in an adult after a brachial plexus injury. We have to dissect all the mass, flexor pronator mass, keep the nerves that are going to innervate the muscles, and traction until the elbow gets good traction with around 80 degrees of flexion. It gives you a good range of motion. The problem with this procedure is if we do a lot of traction, and if there's an active or any, how do you call that? Compensation of the movement, they're going to have a Steindler effect. That is, they have to flex the wrist, to flex the elbow, and that improves the results. And you also can have some lack of extension of the elbow, but normally it's a functional range of motion and the patient's tolerated weight. In order to avoid the Steindler effect, Gilbert says that the one thing that you have to reassure when you're going to use the flexor, the Steindler flexoplasty, is to have or to recover the extension of the wrist first. For hand reanimation, it's also less frequent because global palsies are less frequent than upper trunk and upper extended trunk lesions. But we know also, as my previous speaker said, that if you have global palsies that are not recovered from 3 months, you can operate on them. And these patients before 3 months of age, if they recover, or if are operated before three months of age, they're going to do better. And most of the times they are not going to need any hand reanimation, because it is possible, as Pablo said, to re-innervate the hand. If this recovery or procedures or exploration is after 3 months, they are going to need in average 2 to 4 procedures per patient in order to improve hand function. So the best treatment is prevention. And if you have patients with this characteristic, I recommend you to go for the nerve reconstruction when you see it, if you can, obviously. The most used transfer in these patients are the FCU. With the FCU, that is most of the times recovered or present from the beginning, and they use usually to do finger extension or wrist extension. Also, the brachioradialis, when it is present, is used to make the reanimation of the extensor pollicis longus. We also have, as always, the opportunity or the option of the free functional muscle transfer when there is the possibility, and when the patients and the fathers also want to do it. And to the hand, we have to do it in two times. We have to first take a nerve sural graft or any nerve graft to bank a nerve for the neurotization of the muscle transfer. And you can bank it to the contralateral C7 root, to the intercostals, or to the spinal accessory nerve. So these are all the options. Normally they don't have to be used, especially for the elbow and the hand. And the most important thing to remember is that the shoulder is the most important sequela that these children present. Thank you very much again. If you have any questions.
We already have some questions from the audience, but well, I really would like to go on with the last talk by Andrea about new frontiers in treatment. And then we have several questions to discuss between you three, please. So Andrea, if you can share your screen.
Yes. Are you, hang on. I don't know why I can't, here we go, found it, sorry. All right, so thank you everyone for sticking it out. As Dr. Garcia said, this is the last talk, and this is the exciting stuff, hopefully, just to try to share some thought-provoking ideas about where we might be headed in this field. Again, some of the things I'll be talking about are grant funded, and none of these are independent ideas. Lots of help from lots of people that I work with. So I'll touch on a couple things, a little bit of basic science, some new ideas about diagnostics, as well as timing. We've talked a lot today so far about timing of nerve surgery, and then just some fun stuff on education and what our patients think. So I think these slides are more a question than an answer. I think that as we've looked at our results and our challenges, we really need to understand this nerve injury better. The surgeons who treat this, we are often surgeons who also treat adult brachial plexus injuries. But many of you here are pediatric orthopedists and plastic surgeons, and you know that kids are not little adults. And we really need a better understanding of neonatal neurophysiology. In the US, it's very popular to call the first 3 months after the baby is born the 4th trimester. They're still in this transition period. And one of the hallmarks of this is neuronal pruning. And there have been a lot of studies looking at this motoneuron apoptosis. So when babies are born, they have twice as many motor neurons as they need, and they develop these connections, they interact with the outside world, and they prune the connections that they don't need, and they actually prune the motor neurons themselves. Well, how does that process work when there's a nerve injury right at the moment of birth? This is a very intriguing model. This came from work that was done at UC Davis. They took a neonatal rat and injured the facial nerve, and they found axotomy-induced motor neuron death in these neonatal rats. So if the facial nerve was cut, the corresponding motor neuron in the brain died off. It was not identical. They actually figured out the pathway. The pathway was not identical to this developmental apoptosis that happens, but similar pathway, and clearly something that the newborn is more primed to do than an adult. And what we don't know in the 2 motor neuron system of a brachial plexus injury, where we go from the brain to the spinal cord out to the arm, how that compares to this facial nerve model, but I think a very intriguing model. One of the ways that this plays out, again, this is a rat study, and demonstrating the plasticity that happens in the brachial plexus. So here, neonatal rats had a crush injury to C5 and C6, And what they found then is that there were decreased C5 and C6 motor neurons in the spinal cord, but those rats went on to supply the biceps with C7 in maturity. And so there's a lot of plasticity that's going on in these babies that we as surgeons don't see. We don't know which nerve is going to which muscle. We know which ones they're supposed to go to, but this can influence the results in ways that we're not fully addressing with our surgeries. And so I think that this biology and understanding the biology of the infant really needs to be part of our ultimate solution for these kids. This was a study done at Children's by our cerebral palsy group. And I'll just share this again to demonstrate the plasticity of the nervous system in young children. So for here, these are actual images of the somatosensory pathway on MRI for different groups of kids. And so this is a typically developing kid. This is a child with hemiplegic CP, and this is a child with diplegic CP. And what you can see is this really impressive remodeling of the somatosensory pathway around this infarct in a child with cerebral palsy. And so I think, again, we just need to understand better all the ways that this that the nervous system is plastic and how we might use that to our advantage. Because I think right now we're not really using it to our advantage. And so this is a basic scientist that I've started working with, named Dr. Whited. She has an axolotl lab. This is an axolotl ready for his close-up. And she studies how nerves are part of the regeneration process in axolotl. And so we are looking at gene expression in the neuromas in infants and comparing them to gene expression in a regenerating limb in juvenile salamander to understand what's different and what we as people are missing in our inability to regenerate here. But I think in general, we need more basic scientists who are interested in this problem. It is a very, the brachial plexus injury is not a problem that is really talked about in basic science. It's not cool. We need to get more smart scientists helping us with more biologic solutions for this problem. So that's certainly a goal of mine. So next, just wanted to touch on some research we're doing on diagnostics. Dr. Zancoli mentioned very well the issues with many of these. And for those of you who treat adults, you know that an adult with a brachial plexus injury, they'll go get multiple images. They'll have an MRI, a CT myelogram, EMG, nerve conduction studies. And in babies, we don't do any of these things. One of the reasons is the inaccuracy. We wonder how much an MRI really helps us over our physical examination. If we're going to go do our brachial plexus exploration, how much does it help us to have that information beforehand when we're basically doing the same operation regardless and finding out at the time what we're going to proceed with? Although MRIs can be good at detecting avulsions, many times our surgeries in babies are for nerve ruptures and neuromas that are not conducting. And so how does the MRI help us with that? In addition, there's more difficulty with children in terms of not wanting to do painful procedures, not wanting to do things that take a long time and require sedation. And those are all very good concerns. But I think, we also need to understand that from a parent perspective, what we do now involves a lot of waiting. And so our typical plan is a baby that's born with a brachial plexus injury goes through repeated serial clinical assessments, oftentimes returning to our clinic monthly over 6 months. And every time we say, we don't know if this baby is going to need an operation. It can take 6 months. And this is Dr. Vellerman, who I told you all about earlier. We're socially distancing. But we don't know for 6 months. We're telling parents we don't know how and whether surgery will be needed. And my hypothesis is that it would be a lot better, speaking as a parent, it would be a lot better to know early on, does my kid need surgery? Do I have to plan for this? And if they don't, that's a lot of worry off of my mind. If I know at a month of age that my baby is going to recover. And so if we could come up with an early high resolution MRI that doesn't need to be done under sedation, that doesn't need contrast, that doesn't need radiation, then that would be a great test. And that would shorten our time to surgical decision-making for allowing us to prepare for the babies who need surgery, but almost more importantly, eliminating that worry for the families that don't need surgery. And so this is a study that is currently in process. It's called Nap Time. And this is a multi-center study at 3 centers in the US. We use what's called a feed and rep technique. So the infant is either breast or bottle fed by mom, and then swaddled and placed in the MRI scanner in a swaddle. Done between 28 and 90 days of age. There's no sedation, there's no contrast, and we use a volumetric sequence that we can get done in 8 minutes. That gives us a lot of spatial resolution and soft tissue contrast and the ability to manipulate the images afterwards. But we do have to get the babies to sleep, and so it doesn't really take exactly 8 minutes, but the scan itself is 8 minutes. And we have lots of tricks for getting the babies to sleep. And then once we do that, our neuroradiologists go through and score the MRI. And the purpose of this is, as I mentioned before, avulsions are important, but that's not the whole story for a brachial plexus injury in a baby, right? We want to know where those severe ruptures are. We want to know how many severe injuries there are. And so this is a scoring system that is cumulative. And our thought is perhaps we can come up with a threshold on this score that would mean that surgery is more likely to be helpful. We did publish these results as a pilot study, about 10 kids, and we found that we were able to differentiate, but there's still, in the pilot, there were still some, as you can see in the middle, where maybe a little bit difficult to tell. And so we expanded that. The last time we looked at this was when we had 34 kids. 70% had a successful MRI on their first try. Mean age was just under 2 months. And the mean time spent in the scanner was 30 minutes. So not exactly 8 minutes, but a pretty short period of time, and none received sedation. Our goal is to recruit 100 infants. Prior to COVID, we had gotten just almost up to 70. So we're hopefully well on our way to completing the study, with the goal of perhaps having a threshold score that would predict the need for surgery. Next, I want to touch on the timing a little bit. This is a study that was just recently published out of the TOBY group that I was telling you about earlier. Again, this was 6 centers in the US that had babies enrolled as infants and followed for 5 years. We've just now finished the study, so the last children were enrolled in 2015 and are now in the process of completing their 5-year follow-up. And the whole purpose of this study was to determine the optimal age for nerve surgery. As based on the Europeans, should that be done early, 3 to 6 months of age, versus late, like the US surgeons, at least 6 months of age. We recorded a baseline AMS exam, details of surgeries that were done. We used only physical exam measures as our outcome. So we're only looking really at motor outcomes, AMS, Toronto, and Mallet scores. In the end, 781 subjects were enrolled, and 118 met criteria for inclusion in this study. 80% of them had early surgery at a mean of 4 months. And 67% had early surgery at a mean of 4 months, and 32% had late surgery at a mean of 10 months. This was the infographic, I can't take credit for this, that JBJS made for us, demonstrating the methods and then the things that we looked at. So after we adjusted for severity of injury, the AMS scores were equivalent between the 2 groups. Interestingly, even when we pulled out the global infants and looked at only the hand outcomes, once we controlled for severity, again, the groups were similar. And so really we could not find a difference, even though we were powered to do so, we could not find a difference in the motor outcomes of surgery before or after 6 months of age. And that goes along with our findings that even infants over a year of age can benefit from nerve surgery. This was, again, not a randomized controlled trial. So as you would expect, subjects who underwent early surgery presented earlier and had more severe injuries. But once we controlled for that severity, there was no difference in the motor outcomes. And really the outcome of this, the ultimate conclusion of this, which is perhaps a little depressing and gets back to my, my thought that we need more science here, is that the worse pre-op status led to worse post-op outcomes whenever you did the surgery. That we just are, it's very difficult to overcome these more severe injuries, no matter how good or how early you do your nerve surgery. And then I just want to touch a little bit on some of the more touchy-feely aspects of this condition. As many of you know, this is a very challenging diagnosis for patients and families. There's a lot in the US around blame and litigation and anger. It's a challenging time to convey complex information to the families. And so this is just a little work we've been doing on how we do better on that education. This was a study that we partnered with the Hospital for Sick Kids in Toronto, looking at how we as surgeons deliver information about this diagnosis to our families. This is a good curve to know. This is from adult learning, the Ebbinghaus forgetting curve, and this pertains to our patients who are receiving information about their brachial plexus injury. It also pertains to us as we learn new topics, like in this webinar. We think we get everything right in the beginning, and over time that information just goes away. And so that by 30 days, we retain only 10% of what we've learned. And that is typically when we're seeing patients back in clinic. So a month later, they come back and they seem like they don't know anything. If anyone has ever had that experience, it's not you, it's adult learning. They really don't remember what you told them a month ago. And it's even worse, you know, when you're not getting any sleep and you have a newborn at home. Reviewing information improves your retention significantly. This is why we read our notes and we review our op notes after surgeries. This is a very powerful mechanism, and maybe something that we should be doing more with our families. The study with sick kids, we interviewed parents of kids under 3 and just asked them about the information they received, their knowledge about brachial plexus injuries. And I won't share the whole thing with you, but and we're still working through the data, but one of the most important things, and this is a challenging concept even for us as doctors, is the relationship between the shoulder and the nerves, that this is a very challenging concept for families. And so if we want someone to continue follow-up after we've told them they don't need a nerve surgery, they really need to understand what it is that we're following them for. They need to understand that this nerve injury can cause a shoulder problem. And that's very difficult to convey early on. I think that we need better ways of providing information, and not just in the 15-minute in-person in-office visit. We're working at Children's on handouts, websites, videos, animation. I think lots of repetition is needed to help convey this complex information. And then lastly, none of this really matters unless it matters to our patients. And I think, you know, when it comes back to the congenital topics we were discussing earlier, as well as with brachial plexus injuries, it doesn't matter that we think we did a good job. It matters that our children, our patients are able to function and to have happy, successful lives. I think brachial plexus injury in particular, we need to take a more global view. We see children in a very controlled environment in our clinic, but how does the Mallet score, you know, the fact that they can do this, how does that translate to the use of their arm in real life? And are we measuring what really matters? Does the Mallet score matter for their life? Does it matter that they had to go to the office so many times and have so many surgeries and miss out on school and other things with their friends? We don't really know the relative weight of the interventions and the rest of their lives. And so the idea of this current study that we're just getting underway is to combine several centers in the US as well as sick kids in Canada and perform a cross-sectional study where we ask our patients, we ask them lots of questions across multiple domains of quality of life, and then compare those to our clinical measures to see whether the things that we think are important as doctors, whether those are really important to our patients and their families at all. Fortunately, we do have the funding, if we can get back in the office, to start working on this summer. And this may drive a lot of how we think about things. We may be totally off the mark in terms of what we as surgeons think is important. And so I look forward to hearing from our patients what's really important to them. And that is all. Hopefully we can move on to the discussion. Thank you.
Thank you so much, Andrea. This was really enlightening for all of us. We have several questions, and I think we will have some more now. I'm going to the last one, which is the one I'm seeing here from Daniela Gutierrez, one of our residents. She's asking, Dr. Bauer, are you researching neurotrophic factors for axonal regeneration and brachial plexus injuries, like brain-derived neurotrophic factor, which is being researched for spinal cord injury? How is it going with neuromodulator?
I think that research is super interesting. There are a couple of different factors that people are studying. We do not have a big nerve regeneration lab here at Children's. And I think that I've actually had a lot of difficulty finding people who are interested in applying this basic science in the neonate. And I think that research that's being done is being done in adult models and adult rat models and adult, humans. But I think that we do need more, and we're actually in the process, if you know anybody, of looking for someone to work with us on those sorts of things, because it's really how this all applies to babies is really understudied, and we currently don't have an expert in that here.
Yeah, it's a tough subject. We have another question from Maria Cristina Rodriguez from Barranquilla. If you have a patient 1 year of age with a C5, 6, 7 injury with recovery of elbow flexion, but no good triceps, deltoid, supra, and infraspinatus, would you consider FCU branch as a donor for axillary nerve? If not, any suggestions?
So I think in that case, I have never done an FCU branch to the axillary nerve. I think that the reach would be hard up there. You would have to be high enough up that you would be taking a lot of the ulnar nerve, which would worry me a little bit. I don't know if others have done that, but I would, in this case, the fact that you have self-recovery of the elbow flexion lets you know that C6 is not avulsed. And so for me, this would be, even at a year of age, this would be an exploration and probably grafting. And I think that's a tough call because you're going to go down to nothing. You're going to lose that biceps at first, but you have to, have faith in the numbers that more than 95% of those will come back. And so I would do an exploration and probably graft from C6 to include the deltoid as well as the biceps, and then use my spinal accessory for the rotator cuff.
Great. Pablo, what do you think about this question?
Yeah, I totally agree with Andrea, and for sure, with 1 year of age, if I have this injury, I don't have experience using the FCU branch for axillary. As she said, you need to go into the axilla, and probably you need to do a lot of intravascular dissection. And usually these C5, C6, C7 injuries, also they have some kind of neuroma in C8 because it's a big injury. So when one does an overlimb transfer, one needs to check that you have an FCR and a good FCU strong, because you want to transfer a good fascicle, not a weak fascicle. If not, probably you won't get the result that is expected. So with 1 year of age, I will go for the brachial plexus, look for the best route, and go for shoulder, as Andrea said, to the posterior division of the upper trunk to reinnervate the shoulder, spinal accessory to suprascapular, and I will use the FCU if possible to go to biceps.
Great, thank you. We have another question by Miguel Hernandez. Hi, Miguel. We met several years ago in Sacramento when I met Andrea too. So welcome, Miguel. Which is the best time to perform a subscapularis release using the Carlios approach? That's a tricky question.
For me, I think that the intra-articular approach is stronger. And so for a more dysplastic joint, I would be more likely to do an intra-articular release, which I do through the scope. My boss, Peter Waters, does it open through the axilla. I think it doesn't matter how you get to the joint, but I would, I think that's a stronger procedure. So, and maybe, I don't know, maybe this is just my experience with the Carlios. To me, it doesn't seem as strong. And so I would only do that maybe in a younger child or or less severe contracture. I think it matters more the extent of the dysplasia than the age. But I don't know what others think.
Pablo or Sabrina?
The younger, the better, but I've done that in older children and it works. Not as good as if they were younger, but it works, something.
Okay. Now, Francisco over here, he has some questions for you all. I'll give you the mic.
So I have a couple of questions about the osteotomy around the shoulder. So unfortunately, we have a lot of cases with posterior dislocation. And usually we evaluate using the CT scan. What do you think about this kind of procedure, especially the osteotomy, the results? Because I don't feel real comfortable to do that. What do you think about it?
The glenoid osteotomy?
Glenoid osteotomy, yeah.
Yeah, it's not a very comfortable procedure, huh? I think for that, if again, I think, you know, Sabrina's point, if you can get those patients understanding that this is going to be an issue and coming to you sooner, it's better. It's easier to remodel the joint in a 2-year-old. It's just like the hip, you know, it just is easier. When you're stuck with a 4 or 5-year-old and a higher grade dysplasia, I think there is a role for the glenoid osteotomy. I think for me, Waters 4 in a child who's 4 or 5 or 6, where I think I'm in the sweet spot of I can acutely correct the glenoid and the humeral head will follow. The humeral head will still remodel. I think that's probably the right age and situation. And then the CT scan is very helpful. I use that for my planning to know how far back from the glenoid should I be, how long do I think my osteotomy, how wide is it going to be, what can I fit in there? I think I need a lot of planning for that because you can't see anything when you're doing it. But I'd say if that same child at age 10, maybe the humeral head now won't remodel and I would do more of a humeral osteotomy. And I think we shouldn't forget about the humeral osteotomy. I think the results of those are quite good. It's a standard orthopedic operation with good long-term results.
Yeah, I agree. I don't have any experience with the glenoid osteotomy, but I do have with humeral osteotomy and it works really well.
Yeah, I also agree that also with the humeral osteotomy, you put the hand, the forearm, and the extremity in a better position in these children. And to have the extremity in a better position in daily life activities also stimulates the representation in the cerebral cortex. So they will use more the extremity, they will stimulate more the extremity, and they will develop more the extremity in the cerebral cortex. So it's not only to put the forearm, the extremity in the position, is also the development of the brain of that extremity, I believe. And to have an extremity in a good position will stimulate that the brain development. I don't know if you agree.
Yeah, and you know, when they're older, they already have the compensation engram in the cerebral cortex. And it is completely difficult to change that when they use it for a long time. So it is better to position the extremity. And a thing that I forgot to say during my talk was that you have to have some range of movement between adduction
se van a encargar
and
de producir
adduction and rotation, external rotation. So you have to be aware of that. You have to have at least 100 degrees of range of movement.
Okay, I have another question about the co-contractions. So, you know, when I was with Dr. Michelle James and Dr. Bauer in Sacramento,
con producciones
elbow contractions. So, you know, here in Colombia, we don't have a lot of cases like that. So what is your approach about the elbow contraction? We usually use just buttocks. Do you think that we can perform supraselective neurectomy in order to improve, for example, the elbow bending? What do you think about that?
Like masturbation too?
I think that's a little, to me, it's scary in these, because it's not like it's not like CP. So you can do that in CP. In CP, it's a spastic muscle though. It's not a functioning muscle. In these, it's the weak one that's the problem. It's not that the one that's contracting is a problem. So, and we typically see excess contracture of we can see either, but I'm not sure. I don't think I would be bold enough to do that because the problem here is that they don't have enough axons, they don't have enough motor input, and I just would be afraid to take out more. But I love the idea in CP. I think that's super interesting, and we've started dabbling in that a little bit here. Interested what others, yeah.
It's very interesting that I always think when we have a neuroma that these are disorganized axons and fibers going through scar, and for example we have a C5, C6 neuroma, so the information comes from the brain firing again, passing through this neuroma, and everything will fire together, no? Shoulder, elbow, but I think what it means is that we have some renervation of the muscle. So maybe what we need to do is to find another way to reconnect that muscle. So for example, we have motor end plates that are being renervated through the neuroma. So probably in those cases that we have a live muscle, although the childs are older, we have a nice a live muscle. So probably we can do an overland. And in that way we can re-educate elbow flexion through another way, through like a nerve transfer. It's just a thought, but I believe we need to think different ways to attack a different function sometimes when we have these two co-contractions.
Okay, so I don't know
Tenemos aquí la superficie mucosa y acá arriba qué células había.
Miguel.
Jimena, no has hablado.
Hi everyone. It's great to hear you again, Andrea, Pablo, and Luis. I'm very happy to share some time with you. Here in Mexico, in Shriners Hospital, we are running a telemedicine brachial plexus clinic with Dr. Scott Gauser. We have a lot of patients who are older than 1 year. So is continuously dealing with something like the Damocles sword above our heads, because there are no specific treatment lines for these kids. But we have learned some good things from our experiences, especially with external rotational osteotomies. One of the problems we have with that is that usually we overcorrect these kids and we lose the midline. So it is very important to have this in mind if we are dealing with these kids, because we can lose a lot of function if this midline is away with this kind of osteotomy. So you have to make a very precise measurement before surgery in order to achieve a very good rotation in an external position, and preserving the ability of the patient to have an active approach to the midline. So it is something very, very important for us. We stopped to perform these osteotomies in some kids, especially with the ones with more severe affections, because we're trying to get better results instead of just different kids. So I think it is very, very important to understand the functional needs of the kids, and to keep them in a physical therapy program for long term, because some of the abilities that are recovered in time are lost because they don't have a very good approach for physical therapy in the post-operative period. Luis?
Yeah.
That was it. So
now everybody heard you. So what do you think, Andrea and Pablo and Sabrina?
I think it's an excellent point. I think with the arthroscopy particularly, you have to be careful that you can overdo your release, and we have to again come up with what's important. I think that speaks to some of this outcome work that we're doing. You know, this Malay score is designed to make us look good. We're so proud of ourselves that we can put the hand up here, but does that matter to the child or not? And you know, not being able to button your own pants is pretty embarrassing, and maybe that's a much bigger problem than whether you can catch a ball up here. And so I think that that's an excellent point, and we really need to make sure that we're not, you know, doing things like you said just to make them different, but really trying to improve the function in ways that matter to our patients.
I think there's another approach we can use, and I heard it from actually from Enrique Vergara, and he told me to do first the release, and after the release, if everything is good, if the children doesn't recover external rotation, because sometimes they do, so we can go and do the transfers. That's a conservative approach that could help us also.
Okay, any more thoughts?
Yeah, I have a last one. Sorry. You know, do you have any reason to perform any kind of procedure just to try to recover the or maybe to perform a neurocitation in order to get triceps control. You know, some papers try to follow this kind of idea. Do you think that it's a good idea? Nobody's there.
Did you hear Francisco?
No.
I'm not sure I understood.
Me neither.
So, you know, some papers try to
¿Con sonido o sin sonido?
I don't know.
¿Con sonido?
Listen to me.
It's like sound in the back. We cannot hear well.
Okay. So it's any reason to
Now
perform
you're better.
neurocitation or nerve transfer in order to get more control in the elbow extensions? No, because all the time we try to improve the elbow flexion, but you know, some patients, they have some requests about the elbow extension.
I know in adults, they do intercostals to radial. I don't know if that can work. In children, never done that, but you can do it. Or also the first, the medial pectoral be used also, I don't know.
Yeah, we sort of don't think about it, you know, and it's a good point that we don't focus on it. I agree. I think the intercostals are a possibility. I can tell you, I've had one case where the elbow extension got worse after a radial to axillary transfer. And you think, I always feel like I could take all the triceps branches I want and it's still going to be fine. And it was not fine. And I wonder in those cases, could you then, you know, and she had, it's tough. If you can't extend your elbow, it's tough. I think, you know, we don't focus on it, but for certain kids that could be a problem, you know, combined with their other deficits that could become an issue. And so I think maybe I would try the intercostals if this child comes to surgery. That's what I might do.
Oh, Dr. Bauer,
Pacho,
questions.
Pacho, you mean in total pulses, what to do for triceps, correct?
Yeah.
What? So
you don't have control in the elbow.
So in total pulses, you are also looking to go to the lower trunk. So the lower trunk, the posterior division of the lower trunk will give you the long head of the triceps. So that will be a way to try to reconstruct triceps during total pulses. Like in the one procedure, you go phrenic to posterior division lower trunk, that will give you triceps. But what Andrea said is very interesting. According to the transfer of a radial nerve branch to axillary. One thing I learned to Anil Bhatia is that when you are going to do that transfer in adults, but we can apply this for kids also, we need to palpate the FCR because FCR is C7. So if we don't have FCR, we don't have C7. And if we use the long head of the tricep branch that is from C8 to axillary, we don't get any triceps at all after that. So that probably is in this kind of extended upper trunk lesions, maybe we need to check the FCR because if we use the long head of the tricep, that will be mostly the only part that will be working. We will lose the triceps if we pass it. I don't know if it is clear, maybe.
Yeah, and what do you use in that case?
Well,
intercostals?
Yeah.
Or contralateral C7?
Well, maybe as in this case that I show, maybe that's a good opportunity. I know thoracodorsal is mostly C7, but it has some contribution from C8. So maybe, you know, it's an opportunity to explore a subscapularis, thoracodorsal. I don't know. What do you think? It's also another option. In adults, you know, Anil Bhatia is a person that he did a lot of intercostals in India. And he told me it's difficult to, in adults, to recover axillary and triceps with intercostals because the rehab, because it's in the back. So the adult cannot see what is kind of rehabilitating, and it's not as good as intercostal for biceps. So that is something also to have in the head.
There is a question from the YouTube audience for the panelists. It's from Daniel Restrepo. Do you have any thoughts or any experience regarding PEG, polyethyl glycol, in nerve fusions? It's a new topic. Do you have any experience with PEG or any thoughts about that?
No, again, I think it's super exciting, but I have not, I don't know that people are using it clinically yet.
No, we're in the third world. We don't have that. That's sad, but true.
No idea. When I saw the question, I had no idea what it was. Maybe if Daniel can tell us about it, can you write? I have a very simple question regarding technique. Do you rely only on fibrin glue, or do you always add a couple of stitches?
Most of the time, a couple stitches, but it depends on the difficulty to put together the nerves. Sometimes you are not able to do it because they're too small or too divided. That is easy, but most of the times I use the 2 stitches with the fibrin glue.
Yeah, I often end up putting in a stitch, but I think of it as a necessary evil. I think if you need it to get your alignment, you need the fascicles to be lined up, or if you're worried about the tension, then you need it. But I know that every spot I put that stitch is going to be a scar, and so I try not to put a lot in. And for something that sits very nicely, like the Oberlin usually sits very nicely, and it's just one fascicle. Any place you put a stitch is going to be a scar and a fascicle. So I try really hard not to do it in those cases, and usually I don't.
Okay. Miguel, you had something else?
Yeah. Regarding the osteotomies at the glenoid, doctors Sangoli have written to lots of years before in the growing hand to discourage these procedures because the glenohumeral joint has a different behavior than, for instance, the hip. It's not a dysplastic hip because this is a neuromuscular problem. So they consider this is a big mistake to perform something like the procedures you perform for a dysplastic hip. So it is not recommendable to perform. That's why you don't see it usefully at these times. In second place, we have some problems, especially when we have lower trunk injury to stabilize, for instance, the forearm in a neutral position. So it is very useful to perform extraarticular arthrodesis, putting a bone block between the radius and the ulna at the distal third of the forearm, just to block the forearm rotation in a neutral position. And we have found that this kind of procedures is very useful for having a better control forum using for assistance to the healthy extremity. So I think I find it very useful to control these very troublesome issues, especially in those kids who are impaired the most. So I don't know if anyone performed this kind of surgery.
I have not. I've found more contractures in the forearm than instability. And so I have done osteotomies or reroutings to change the position, but I've never done what you described with the bone block.
So the forearm usually in total or global will go into supination and kind of ulnar deviation and extension of the wrist. And what can happen is that it can be mobile and reductible, or the distal ulna can be dislocated anteriorly. If we have the distal ulna dislocated, we cannot perform a soft tissue procedure, of course. If we can make a release and move, we can do maybe a tendon transfer, like ECU through the interosseous membrane into the first ECRL, sorry, in order to correct ulnar deviation and pronation. If already we have dislocation at the DRUJ, at that time we can do a block and put the forearm in 20 degrees of pronation or neutral in order to put the hand in a better position. But already there must be like dislocation at the DRUJ.
Wow.
Thanks very much.
Thank you, Miguel, for participating. Well, I think we have covered the subject very, very deeply. We have had the opportunity of talking about the clinical features, the surgical planning, surgical technique, and most important for the, I think, newer procedures and the reconstruction procedures. At least Pablo has his mate with him, which is good. We had the chance to have some coffee and we had a great conversation and discussion. So I want to thank you all, mostly the panelists, Andrea, Pablo, and Sabrina, for coming with us today. I want to thank Francisco and Julian for all the setup. And we had, I think, a very, very fruitful session today. So thank you all. Thank you to the audience. And I hope we will see you in person for a better and deeper version of this course, maybe next year, maybe in 2 years. We will see how we can fix this. Okay? Thank you all.
Thank you.
Thank you.
Thank you so much.
Andrea, Sabrina, thank you.
Bye. Thank you.
Thank you.
Thank you. I'm closing now. Bye-bye.
Bye.